Heart embryology. What does the embryonic structure, truncus arteriosus, give rise to? Truncus arteriosus gives rise to ascending aorta and the pulmonary trunk. What does the embryonic structure, bulbus cordis, give rise to? Bulbus cordis gives rise to the smooth part of the left and right ventricle. What does the embryonic structure, primitive ventricles, become? Primitive ventricles becomes trabeculated left and right ventricles. What does the embryonic structure, primitive atria, become? The primitive atria becomes the trabeculated left and right atria. What does the embryonic structure, left horn of sinus venosus, become? The left horn of sinus venosus becomes the coronary sinus. What does the embryonic structure, right horn of sinus venosus, become? The right horn of sinus venosus becomes the smooth part of the right atrium. What does the embryonic structure, right common cardinal vein and right anterior cardinal vein, become? The right common cardinal vein and the right anterior cardinal vein becomes the superior vena cava. Truncus arteriosus. Describe how neural crest eventually becomes ascending aorta and the pulmonary trunk. From the neural crest migration, it eventually has truncal and bulbar ridges that spiral and fuse to form the aorticopulmonary, the AP septum, and the AP septum eventually becomes the ascending aorta and the pulmonary trunk. What are some of the pathologies that can arise if there is a problem in the truncus arteriosus due to failure of migration or due to the failure to spiral and fuse? Some of the pathologies that can arise include transposition of great vessels, which is failure to spiral, also Tetralogy of Fallot, which is a skewed AP septum development, and also persistent truncus arteriosus, which is due to partial AP septum development. Interventricular septum development. Describe what you see on page 250, the picture 1 under interventricular septum development. On this picture, you see the interventricular foramen. You also see the atrioventricular canals as well as the muscular ventricular septum. Describe the second step in the interventricular septum development by looking at the picture on page 250, number 2. In the second picture here, you see the AP septum rotates and fuses with the muscular ventricular septum to form membranous interventricular septum. It also closes the interventricular foramen. Describe what you see on picture 3 of the interventricular septum development on page 250. On image 3, you see the growth of the endocardial cushions, which separates the atria from ventricles, and this contributes to both atrial separation and the membranous portion of the interventricular septum. What are some of the pathologies that can arise if there is an improper neural crest migration into the truncus arteriosus? If this were to happen, it would result in transposition of the great arteries or a persistent truncus arteriosus. What condition can arise if there is a defect in the membranous septal? If there is membranous septal defect, it causes an initial left to right shunt, which later reverses to right to left shunt due to the onset of pulmonary hypertension. This is called Eisenmenger syndrome. Interatrial septum development. What is happening on picture 1 of the interatrial septum development? In picture 1 here, you see foramen primum narrows as septum primum grows towards the endocardial cushion. What is happening on picture 2 of the interatrial septum development? In the second image here, you see perforations in the septum primum, and this will form the foramen secundum. At this step, foramen primum disappears. What is happening on image 3 of the interatrial septum development? On image 3, you could see that the foramen secundum will continue to maintain the right to left shunt as septum secundum begins to grow. What is happening on image 4 of the interatrial septum development? In image 4, you see that septum secundum contains a permanent opening called the foramen ovale. What is happening on image 5 of the interatrial septum development? On image 5, you could see that foramen secundum enlarges and the upper part of septum primum degenerates. What are the remaining steps of the interatrial septum development? The remaining steps are that the portion of the septum primum that remains will form the valve of foramen ovale. Septum secundum and septum primum will fuse together to form the atrial septum, and foramen ovale usually will close after birth and this happens due to increase in left atrial pressure. So based on what we just talked about, what is the reason why there would be a patent foramen ovale? The reason for a patent foramen ovale is because there would be a failure of septum primum and septum secundum to fuse after birth.
Fetal erythropoesis. What is erythropoesis? Erythropoesis is the production of the red blood cells. Where does erythropoesis occur in a fetus that's 3 to 10 weeks old? In a fetus that's 3 to 10 weeks old, the erythropoesis occurs at the yolk sac. Where does erythropoesis occur in a fetus that's 6 weeks old till the time of birth? Fetus that is 6 weeks old till the time of birth, the erythropoesis occurs in the liver. Where does erythropoesis occurs in a fetus that's 15 to 30 weeks old? In a fetus that's 15 to 30 weeks old, the erythropoesis occurs in the spleen. Where does erythropoesis occur in a 22-week-old fetus as well as in adults? Erythropoesis for a 22-week fetus as well as in adults happen in the bone marrow. What is the mnemonics to help you remember fetal erythropoesis? The mnemonics to help you remember fetal erythropoesis is young liver synthesized blood. That's Y for yolk sac, L for liver, S for spleen, and B for bone marrow. What are the subunits of fetal hemoglobin? The subunits of fetal hemoglobin is 2-alpha and 2-gamma. What are the subunits of adult hemoglobin? The subunit of adult hemoglobin is 2-alpha and 2-beta.
Fetal circulation. What is the PO2 of the blood in the umbilical vein? The blood in the umbilical vein has a PO2 of around 30 millimeters of mercury. How much is the blood in the umbilical vein saturated with O2? The blood in the umbilical vein is around 80% saturated with O2. One thing to note about the fetal circulation is that the umbilical arteries have a low oxygen saturation. Describe the importance of ductus venosus in fetal circulation. The importance of ductus venosus is to bypass the hepatic circulation. The way it does this is the blood that enters the fetus through the umbilical vein, it's conducted via the ductus venosus into the inferior vena cava, and in this way it bypasses the hepatic circulation. What is the importance of foramen ovale in fetal circulation? The importance of foramen ovale is to take most of the oxygenated blood that's reaching the heart through the inferior vena cava and divert this blood from the right atrium to the left atrium and then to the left ventricle and eventually get it pumped out through the aorta and to the rest of the body and the head. What is the importance of ductus arteriosus in fetal circulation? Ductus arteriosus in fetal circulation gets the blood eventually to the descending aorta. The way it does this is all the deoxygenated blood that enters the right atrium from the superior vena cava enters the right ventricle. Then this blood that's in the right ventricle now is expelled into the pulmonary artery and then passes through the ductus arteriosus into the descending aorta. This blood eventually makes its way back to the placenta. Describe how foramen ovale and ductus arteriosus closes at the time of birth. At birth, when an infant takes a breath, it will lead to decrease in the resistance in the pulmonary vasculature. Therefore, the blood is now freely able to move into the lungs, and this causes an increase in the left atrial pressure compared to the right atrial pressure. Because the blood is freely able to move through the pulmonary vasculature, it makes sense that the pressure in the right atrium is going to be much lower than the pressure in the left atrium. Because of this reason, it will cause the foramen ovale to close. This will now be called fossa ovalis. Then what would happen is because of the increase in oxygen leads to decrease in the levels of prostaglandins in the body. This causes the ductus arteriosus to close. So at birth, both the foramen ovale closes and becomes fossa ovalis, and the ductus arteriosus closes. What drug can close the patent ductus arteriosus? Indomethacin closes the patent ductus arteriosus. What keeps the patent ductus arteriosus open in some conditions where you would require the PDA to stay open? Prostaglandins E1 and E2 keep the PDA open. Fetal postnatal derivatives. What does the umbilical vein becomes postnatally? The umbilical vein becomes ligamentum teres hepatis, which is contained in the falciform ligament. What does the umbilical arteries become postnatally? Umbilical arteries becomes medial umbilical ligaments. What does ductus arteriosus become postnatally? Ductus arteriosus becomes ligamentum arteriosum. What does ductus venosus become postnatally? Ductus venosus becomes ligamentum venosum. What does the foramen ovale become postnatally? Foramen ovale becomes the fossa ovalis. What is allantois? Allantois is an embryonic structure that helps the embryo exchange gases and handle liquid waste. What is notochord? Notochord is a cartilaginous skeletal rod that supports the body during the embryonic phases. What does the allantois become postnatally? Allantois becomes urachus median umbilical ligament. What is the urachus? Urachus is part of the allantotic duct between the bladder and the umbilicus. What is the remanent of the urachus? The remanent of the urachus is the urachal cyst or the urachal sinus. What does the notochord become postnatally? Notochord becomes the nucleus pulposus of the intervertebral disc. Coronary artery anatomy. Describe the picture that you see here on page 253 of the coronary artery anatomy. In the picture here of the coronary artery anatomy, you see the left main coronary artery known as the LCA. It gives off a couple of different branches, one of them being the LAD, which is the left anterior descending artery, which is one of the most important arteries of the heart. There's also the left circumflex coronary artery, which goes to the back of the heart, and there's also the left marginal artery. Going now onto the right side, you see the right coronary artery known as the RCA. There's also the acute marginal artery and the posterior descending artery, also known as the interventricular artery. What regions of the heart are supplied by the left anterior descending artery? The left anterior descending artery supplies the anterior 2/3 of the interventricular septum, anterior papillary muscles, and also the anterior surface of the left ventricle. So the major part of the anterior left ventricle is supplied by the LAD. What regions of the heart are supplied by the left circumflex coronary artery, also known as the LCX? The left circumflex coronary artery supplies the lateral and the posterior walls of the left ventricle. So basically, the posterior left ventricle is supplied by the left circumflex coronary artery. What regions of the heart are supplied by the acute marginal artery? Acute marginal artery supplies the right ventricle, mostly on the anterior side of the right ventricle. What areas of the heart are supplied by the posterior descending, also known as the interventricular artery, the PD? Posterior descending artery supplies the posterior 1/3 of the interventricular septum and also the posterior wall of the ventricles. What artery supplies the SA and the AV node? SA and the AV nodes are usually supplied by the RCA, which is the right coronary artery. What does it mean when the heart is said to have a right dominant circulation? Right dominant circulation is said to happen in about 85% of the patients, in which the posterior descending arises from the right coronary artery. What does left dominant circulation mean, referring to the coronary arteries? Left dominant circulation means that in about 8% of the cases, posterior descending arises from the left circumflex coronary artery. What does codominant circulation mean when referring to coronary artery? Codominant circulation means that in about 7% of the patient, the posterior descending artery arises from both the left circumflex coronary artery as well as the right coronary artery. Which coronary artery most commonly gets occluded? Coronary artery occlusion most commonly occurs in the left anterior descending artery. Do coronary arteries fill up in a diastole or do they fill up in a systole? Coronary arteries fill during a diastole. What is the most posterior part of the heart? The most posterior part of the heart is the left atrium. What happens in a condition when there is an enlargement of the left atrium? Enlargement of the left atrium can lead to dysphagia, and this happens due to the compression of the esophagus, or it can also lead to hoarseness, and this happens due to the compression of the left recurrent laryngeal nerve, which is a branch of the vagus nerve. What are some of the conditions in which transesophageal echocardiography would be useful in diagnosing? Transesophageal echocardiography would be useful in diagnosing left atrial enlargement, aortic dissection, or thoracic aortic aneurysm.
Cardiac output. What is the equation of cardiac output? Cardiac output is stroke volume times the heart rate. What is the Fick principle? Fick principle is rate of the oxygen consumption over the arterial oxygen content minus the venous oxygen content. What is the equation for mean arterial pressure, also known as MAP? The equation for mean arterial pressure is cardiac output times the total peripheral resistance. What is a second equation of the mean arterial pressure? The second equation of mean arterial pressure is that it's 2/3 diastolic pressure plus 1/3 systolic pressure. What is the equation of pulse pressure? The equation of pulse pressure is that it's systolic pressure minus the diastolic pressure. What is the pulse pressure proportional to? Pulse pressure is proportional to stroke volume. What is the equation of stroke volume? The equation for stroke volume is cardiac output over the heart rate, or end diastolic volume minus the end systolic volume. Describe how cardiac output is regulated during exercise. Cardiac output is maintained by increase in heart rate and increase in stroke volume during early stages of exercise. During the late stage of exercise, cardiac output is maintained by increase in heart rate only. What happens if the heart rate gets way too high for the body to handle? When the heart rate gets way too high, diastolic filling is incomplete and therefore cardiac output becomes decreased. That means the heart is not pumping enough blood out, and this results in a ventricular tachycardia.
Cardiac output variables. What are all the things that affect stroke volume? Stroke volume is affected by contractility, afterload, and preload. What is a mnemonic to help you remember stroke volume is affected by all these things? The mnemonics is SV CAP. CAP stands for contractility, afterload, and preload. What causes the increase in stroke volume? Stroke volume is increased when there is an increase in preload, decrease in afterload, or increase in contractility. What are all the reasons that causes an increase in contractility and therefore an increase in stroke volume? All the reasons that cause an increase in contractility includes catecholamines, increase in the intracellular calcium, decrease in the extracellular sodium, and digitalis use can all lead to an increase in contractility. How does catecholamines cause an increase in contractility? Catecholamines increases the activity of the calcium pump in the sarcoplasmic reticulum, therefore causing increase in contractility. How does the decrease in the extracellular sodium cause an increase in contractility? The decrease in extracellular sodium causes a decrease in the activity of the sodium-calcium exchanger, and this eventually leads to an increase in contractility. How does digitalis cause an increase in contractility? Digitalis blocks the sodium-potassium pump. This leads to increase in the intracellular sodium. This will lead to decreased activity of the sodium-calcium exchanger, and therefore there will be an increase in the intracellular calcium. This leads to increase in the contractility. What are some of the life situations that can cause an increase in the stroke volume? The increase in stroke volume can happen due to anxiety, exercise, or in pregnancy. What happens to the stroke volume in a failing heart? A failing heart has decreased in stroke volume. What situations cause an increase in the myocardial oxygen demand? Myocardial oxygen demand is increased with afterload, which is proportional to arterial pressure. It's also increased with contractility. It also increases with heart rate, and it increases with heart size due to increased wall tension. What are all the reasons that would cause a decrease in contractility and therefore decrease in the stroke volume? The decrease in contractility and therefore a decrease in the stroke volume can happen with beta-1 blockade, which decreases the CAMP. It also happens in heart failure due to systolic dysfunction, as well as in acidosis, hypoxia, and this happens in hypoxia due to decrease in PO2, and hypercapnia, because in hypercapnia there is an increase in PCO2, also with non-dehydropyridine calcium channel blocker use. Preload and afterload. What is preload? Preload is ventricular and diastolic volume. So think of this as the load to fill up the heart. What is afterload? Afterload is the mean arterial pressure, which is proportional to the peripheral resistance. To make this easier, just think of this as the load required to push the blood out of the heart. Do venodilators have an effect on decreasing the preload or decreasing the afterload? Venodilators such as nitroglycerin have an effect on decreasing the preload. Do the vasodilators such as hydralazine have an effect on decreasing the preload or decreasing the afterload? Vasodilators such as hydralazine has an effect on decreasing the afterload. What are some of the situations that can cause an increase in the preload? Increase in the preload can happen with exercise, which happens slightly. It can also happen with overtransfusion, which increases the blood volume. And lastly, it also happens with excitement because this causes an increase in the sympathetic activity. Starling curve. What is the force of contraction proportional to? The force of contraction is proportional to the end diastolic length of the cardiac muscle fiber, which is the preload. What are some of the reasons for increase in contractility? Increase in contractility happens with sympathetic stimulation, catecholamines, and digoxin. What are some of the causes of decrease in contractility? Decrease in contractility happens with the loss of myocardium, such as an MI, beta blocker, or calcium channel blockers. Describe the picture here you see of the Starling curve. The picture here first puts cardiac output or stroke volume on the Y curve, and on the X curve it has the ventricular end diastolic volume, which is the preload. Now in normal situation you see the curve here in black, but in situations such as exercise or sympathetic nerve impulses, you would have an increase in the preload as well as an increase in the cardiac output or stroke volume, and therefore the curve would move to the left. Now if you look at the congestive heart failure, the curve moves to the right, and that is represented by the orange curve here. That's just congestive heart failure, and in this case you would have a decrease in the preload as well as a decrease in cardiac output or stroke volume. Now if you look at the red curve here, it represents congestive heart failure with the use of digoxin. Digoxin helps in congestive heart failure by increasing the preload as well as causing an increase in the cardiac output and stroke volume.
Ejection fraction. What is the equation of ejection fraction? Ejection fraction is stroke volume over end diastolic volume. Another equation for this is end diastolic volume minus end systolic volume over end diastolic volume. What is ejection fraction an index of? Ejection fraction is an index of ventricular contractility. What is the normal range of ejection fraction? The normal range of ejection fraction is greater than or equal to 55%. What happens to ejection fraction in systolic heart failure? In systolic heart failure, ejection fraction is decreased.
Resistance, pressure, and flow. What is the equation for the change in pressure? The equation of change in pressure is delta P equals Q times R. Q stands for the flow and R stands for the resistance. What is the change in pressure similar to? Change in pressure is similar to the Ohm's law, which is delta V equals IR. V stands for volt, I stands for intensity, and R stands for resistance. What is the equation of resistance? Resistance is driving pressure, which is the delta P, over the flow, which is Q. And that in turn equals 8N viscosity by the length over pi R4. How does the flow of liquid travel due to pressure gradient? The pressure gradient drives flow from high pressure to low pressure. Based on the equation of resistance, what is resistance directly proportional to? Resistance is directly proportional to viscosity and the vessel length. What is resistance inversely proportional to? Resistance is inversely proportional to the radius to the fourth power. How do you calculate total resistance of vessels put in series? Total resistance of vessel in series can be calculated with R1, the resistance of vessel 1, plus the resistance of vessel 2, plus the resistance of vessel 3, and so on. How do you calculate total resistance of vessel in parallel? The way you calculate this is to take 1 divided by resistance in vessel 1 plus 1 divided by resistance in vessel 2 plus 1 divided by resistance of vessel 3, and so on. What does viscosity depend mostly on? Viscosity depends mostly on the hematocrit. What are some of the conditions that can increase the viscosity of the blood? Some of the conditions that can increase the viscosity includes polycythemia, hyperproteinemic states like in multiple myeloma, and in hereditary spherocytosis. In what condition does the viscosity of the blood decrease? The viscosity of the blood decreases in anemia. What accounts for most of the total peripheral resistance in the body? Arterioles account for most of the total peripheral resistance because they regulate the capillary flow. Cardiac and vascular function curves. Describe the picture here that you see on page 255 describing the cardiac and the vascular function curve. On this picture you see on the y-axis the cardiac output or the venous return, and on the x-axis you see the right atrial pressure or the end diastolic volume. The red curves indicate blood volume and the green curve indicates ionotropy. What does the number 1 represent in this picture? In this picture, number 1 represents the operating point of the heart, where the cardiac output and the venous return are equal. What does the number 2 represent in this picture? Number 2 in this picture represents decrease in the total peripheral resistance. This happens in exercise and an AV shunt, and this results in positive ionotropy as well as increase in blood volume. In this, there's also a higher cardiac output as well as a higher end diastolic volume. What does number 3 represent in this picture? Number 3 represents increase in the total peripheral resistance, and this happens due to hemorrhage before compensation can occur, which shows a decrease in the blood volume, decrease in ionotropy, there's a decrease in the cardiac output, as well as a decrease in the end diastolic volume. What does number 4 represent in this picture? Number 4 represents a heart failure or a narcotic overdose, because in this, there is a decrease in ionotropy. This leads to a decrease in cardiac output, but the venous return is normal, as well as the end diastolic volume is normal. What does number 5 represent in this picture? Number 5 represents the x-intercept of the venous return curve, which is the mean systemic filling pressure. Cardiac cycle. Phases of the left ventricle. What is isovolumetric contraction? Isovolumetric contraction is the period between mitral valve closure and aortic valve opening. So basically, isovolumetric contraction is the time where all the blood is sitting in the left ventricle and the ventricle is now starting to contract, and once it contracts enough, it will eventually cause the aortic valve to open, but until that doesn't happen, it's considered the isovolumetric contraction because the volume levels are not changing in the left ventricle. This is the period of the highest oxygen consumption. What is systolic ejection? Systolic ejection is the period between aortic valve opening and closing. So once the push from the left ventricle gets strong enough, it will cause the aortic valve to open and blood to start releasing. And until the time the aortic valve closes again and stops the blood from releasing into the aorta, this is considered the systolic ejection. What is isovolumetric relaxation? Isovolumetric relaxation is the period between aortic valve closing and the mitral valve opening. So at this stage, there's nothing entering the left ventricle. The ventricles are just relaxing, waiting for more blood to eventually come when the mitral valve opens. But until that doesn't happen, the ventricles are just simply relaxing, and there is no changes in the volume of the left ventricle. There's nothing coming in, so therefore it's isovolumetric, and because there is no changes in the volume in the left ventricle. What is rapid filling? Rapid filling is the period just after mitral valve opening. This means right after a mitral valve opens, there is a lot of blood that's going to squeeze out of the left atrium and go into the left ventricle. So this is the rapid filling phase, because right when it opens, of course, all the blood is going to rush out of the left atrium and try to go to the left ventricle, and this is the rapid filling phase. What is reduced filling? Reduced filling is the period just before mitral valve closure. So of course it makes sense that the mitral valve is about to close, so therefore the blood that's coming out of the left atrium and trying to go into the left ventricle is now starting to slow down. So this of course is the reduced filling. Describe what all is going on in the first picture on page 256 of the cardiac cycle, the phases of the left ventricle. In this picture, on the y-axis, you could see the pressures that are in the left ventricle, and on the x-axis, you could see the volume of the left ventricle. We will start talking about this picture by looking at where it says mitral valve closes. So once the mitral valve closes, this means all the blood is now inside the left ventricle. Once the blood is inside the left ventricle, it starts the isovolumetric contraction, which is represented by the number 1 here. Because of the isovolumetric contraction, the contraction of the ventricles is starting to happen, but the contraction hasn't got to a point where it causes the aortic valve to open. But eventually, once the pressure increases enough to close to about 80, according to the picture here, you will see that the aortic valve will then open. Once the aortic valve opens, all the blood that's in the left ventricle will start releasing into the aorta from the aortic valve, and that will cause the reduction in the volume in the left ventricle. So that you could see here by number 2, because that's the systolic ejection. All the blood is getting out of the heart and going into the aorta, and that is causing the volume to reduce. So that's represented by number 2. Now once the systolic ejection is done and the aortic valve has closed, what's going to happen is the pressure is going to start decreasing because the left ventricle is going to start relaxing. This is the isovolumetric relaxation, because once the aortic valve closes, the ventricles are relaxing. It gets ready for the second phase when the mitral valve opens. So this is the isovolumetric relaxation phase. And now after this, the ventricle is ready for the next cycle. So then again, the mitral valve opens. That will cause all the blood to rush out of the left atrium and go to the ventricle. And that is represented by number 4 and 5. Number 4 is the rapid filling phase. Number 5 is the reduced filling phase. And because of these phases, you could see that the volume is increasing. The pressure hasn't changed because in this point, the ventricle just stays relaxed and accepts all the blood that is coming into the left ventricle from the left atrium. So this is basically how the blood enters the left ventricle and leaves the left ventricle. This picture is a very important picture because it does tell you what happens if there is an increase in contractility in different situations, or if there's an increase in preload, increase in afterload. So clinically, it's a very important picture. So you should use this as a reference to answer some of those questions on what is going on as far as the volume and the pressure is concerned, if there's an increase in preload, afterload, contractility, and things like that. Cardiac cycle. The heart sounds. To answer the questions about heart sound, please refer to the second picture on 256 where you see the blue lining which shows heart sounds. The red and the green lines that you can see right above the heart sounds in this picture represent the cardiac cycle. This picture is similar to the cardiac cycle picture that you could see right above here. These two pictures are the same, they are just represented differently, so you could see different things compared to the heart sounds. So to answer the questions about heart sounds and different things on this page, please refer to both of the pictures. What is the S1 heart sound? The S1 heart sound is when the mitral and the tricuspid valve closes. It's heard the loudest at the mitral area. What is the S2 heart sound? S2 heart sound is the aortic and the pulmonary valve closure. It's the loudest at the left sternal border. What is the S3 heart sound? The S3 heart sound is an abnormal heart sound. It happens in early diastole during rapid ventricular filling phase, and it's associated with increase in filling pressure. What are some of the conditions in which you would be able to hear a S3 heart sound? S3 heart sound can be heard in conditions such as mitral regurgitation, congestive heart failure, and can happen with dilated ventricles, but can be normal in children and pregnant women. What is the S4 heart sound? S4 heart sound is the atrial kick, which happens in late diastole due to high atrial pressure. What is a condition in which you would have the S4? S4 can happen in ventricular hypertrophy because in this, the left atrium must push hard against a stiff left ventricle wall. Cardiac cycle, jugular venous pulse, JVP. Please refer to the second picture on page 256 to answer questions about the jugular venous pulse. What is the A wave of the jugular venous pulse? The A wave of the jugular venous pulse is the atrial contraction. What is the C wave of the jugular venous pulse? The C wave of the jugular venous pulse is the right ventricle contraction, and the reason this is happening is because of the pressure in the right ventricle will cause the closed tricuspid valve to bulge into the atrium. What is the X descent? X descent is the atrial relaxation and a downward displacement of the closed tricuspid valve during ventricular contraction. What is the V wave of jugular venous pulse? This happens due to an increase in the right atrial pressure due to the filling against a closed tricuspid valve. What is the Y descent? Y descent is the blood flow from the right atrium to the right ventricle. Splitting. Based on the picture on page 257 of normal splitting, describe what happens in expiration and inspiration. In the picture here, you see the S1 sound, which is the mitral and the tricuspid valve closure, and in expiration and in inspiration, it closes at the same time. So in expiration and in inspiration, the S1 sound comes at the same time. The A2 stands for aortic valve closure, and the P2 stands for the pulmonic valve closure. So in expiration, you first will hear the aortic sound, followed by the pulmonic sound, and the delay between the two sounds is not that big. It's just a slight delay. First it would be aortic, and then it would be the pulmonic. Now during inspiration, there would be a greater delay. So first you would hear the aortic sound, followed by a bigger delay, then you would hear the P2 sound. Describe physiologically why inspiration causes the normal splitting. During inspiration, there is a drop in the intrathoracic pressure. This leads to increase in venous return to the right ventricle. Now if there is more blood going to the right ventricle, it must pump out that extra blood. So this leads to increase in right ventricular stroke volume. So because of that increase in right ventricle stroke volume, there's also an increase in the ejection time, and because of that increase in ejection time, there is the delayed closure of the pulmonic valve. So during inspiration, it takes much longer to pump out that blood, therefore the pulmonic sound comes a little late, and therefore this is the normal splitting that happens with inspiration. One other thing to note about this that also contributes to this delay is there is a decrease in the pulmonary impedance, which increases the capacity of the pulmonary circulation. This is something that also happens during inspiration and can contribute to the delayed closure of the pulmonic valve. Splitting. What are some of the conditions that can lead to wide splitting? Wide splitting happens in conditions that delay the right ventricle emptying, such as in pulmonic stenosis and in right bundle branch block. Describe what happens physiologically to cause the wide splitting. Wide splitting happens because of the delay in the right ventricle emptying, which causes a delay in the pulmonic sound. And this happens regardless of breath, and this is just something that's an exaggeration of the normal splitting. So everything is wider apart than it would be in normal splitting regardless of the breath. What is a condition that can lead to fixed splitting? Fixed splitting can happen in ASD, which is atrial septal defect. Describe how ASD leads to fixed splitting. ASD causes left to right shunt. This means the blood that's on the left side of the heart will eventually come to the right side of the heart. This leads to increase in the volume of the right atrium and the right ventricle. Now, because of this increase in volume in the right side of the heart, there must be an increased flow through the pulmonic valve, and that, regardless of breath, the pulmonic closure is delayed. So in both situations, expiration and inspiration, the P2 sounds happen at the same time. This is why it's called fixed splitting, and regardless of breath, the P2 sound happens delayed. What are some of the conditions that can lead to paradoxical splitting? Paradoxical splitting happens in conditions that delay the left ventricle emptying, such as in aortic stenosis and in left bundle branch block. Describe physiologically what is happening in paradoxical splitting. In paradoxical splitting, the normal order of valve closure is reversed, so that the P2 sound occurs before the delayed A2 sound. So in this situation, what is happening is that the P2 sound is happening where it normally needs to happen, but the A2 sound is greatly delayed. So therefore, on inspiration, P2 closes later and moves closer to the A2, thereby paradoxically eliminating the split. Auscultation of the heart. What are the areas to listen in auscultation? The areas to listen is aortic area, pulmonic area, tricuspid area, mitral area, and the left sternal border. What is the mnemonic to help you remember the 4 area? The mnemonic to help you remember this is apartment M or APTM. A stands for aortic area, P stands for pulmonic area, T stands for the tricuspid area, and M stands for the mitral area. What kind of murmur can be heard at the aortic area? At the aortic area, you could hear the systolic murmur. What are some of the conditions that can lead to a systolic murmur heard at the aortic area? Some of the conditions that can lead to this include aortic stenosis, flow murmur, and aortic valve sclerosis. What type of murmur can be heard at the pulmonic area? At the pulmonic area, you could hear the systolic ejection murmur. What are some of the conditions that can lead to systolic ejection murmur heard at the pulmonic area? The systolic ejection murmur heard at the pulmonic area can happen due to pulmonic stenosis, flow murmur caused by atrial septal defect, or patent ductus arteriosus. What type of murmurs can be heard at the tricuspid area? The murmurs that can be heard at the tricuspid area includes pansystolic murmur and diastolic murmur. What are some of the conditions that can lead to pansystolic murmur heard at the tricuspid area? Some of the conditions that can lead to this is tricuspid regurgitation and ventricular septal defect. What are some of the conditions that can lead to diastolic murmur heard at the tricuspid area? Some of the conditions that can lead to this is tricuspid stenosis and atrial septal defect. What type of murmurs can be heard at the mitral area? At mitral area, you could hear a systolic murmur and a diastolic murmur. What is a condition that can lead to a systolic murmur heard at the mitral area? Systolic murmur heard at the mitral area can be caused by mitral regurgitation. What condition causes a diastolic murmur heard at the mitral area? The condition that can cause a diastolic murmur heard at the mitral area is mitral stenosis. What type of murmurs can be heard at the left sternal border? The murmurs that can be heard at the left sternal border includes diastolic murmur and systolic murmur. What are some of the conditions that can lead to a diastolic murmur heard at the left sternal border? Some of the conditions that can lead to this is aortic regurgitation and pulmonic regurgitation. What are some of the conditions that can lead to a systolic murmur heard at the left sternal border? The condition that can lead to this is hypertrophic cardiomyopathy. Describe how atrial septal defect can result in murmurs. Atrial septal defect will cause a left to right shunt, which means there would be more blood coming into the right side of the heart. Now, because of this, there would be an increase in flow through the pulmonary valve. This will cause a pulmonary flow murmur and also a diastolic rumble. The reason for this is there would be an increase in flow across the tricuspid valve. One thing to note is that blood flow across the actual atrial septal defect does not cause a murmur because there is no pressure gradient. So there's no murmur associated with the actual ASD. It's just because of that ASD, there would be a larger blood volume in the right side of the heart, and this is what leads to murmur. These murmurs eventually lead to a louder diastolic murmur, and this happens due to pulmonic regurgitation from a dilated pulmonary artery. What is the best area where the machine-like murmur of a PDA can be heard? The best area for this is the left infraclavicular region. Bedside maneuvers and their effect on the heart sounds. What effect does inspiration have on heart sounds? Inspiration increases the intensity of the right heart sounds. What effect does expiration have on heart sounds? Expiration increases intensity of the left heart sound. What effect does hand grip have on the heart sound? Hand grip increases the systemic vascular resistance. This would lead to increase in intensity of the mitral regurgitation, aortic regurgitation, ventricular septal defect, and a mitral valve prolapse murmurs. Hand grip will also decrease the intensity of aortic stenosis and decreases the intensity of the hypertrophic cardiomyopathy murmurs. What effect does Valsalva maneuver have on heart sound? Valsalva maneuver, which decreases the venous return, will decrease the intensity of most murmurs, but it will increase the intensity of the mitral valve prolapse and would increase the intensity of hypertrophic cardiomyopathy murmurs. What effect does rapid squatting have on heart sound? Rapid squatting increases the venous return. It also increases the preload, and it can also increase afterload with prolonged squatting. And because of this, it can lead to decrease in the intensity of the mitral valve prolapse murmur and would decrease the intensity of hypertrophic cardiomyopathy murmurs. What are the conditions that can lead to systolic murmur? Systolic murmurs can happen due to aortic or pulmonic stenosis, mitral or tricuspid regurgitation, and ventricular septal defect. What are the conditions that can lead to diastolic murmur? Diastolic murmurs can happen due to aortic or pulmonic regurgitation and mitral or tricuspid stenosis. Heart murmurs. Name all the systolic heart murmurs. Systolic heart murmurs include mitral or tricuspid regurgitation, aortic stenosis, ventricular septal defect, and mitral valve prolapse. Describe the sound of mitral or tricuspid regurgitation. Mitral or tricuspid regurgitation is a hollow systolic high-pitched blowing murmur. Describe the area where mitral regurgitation can be heard the best. Mitral regurgitation is loudest at the apex and it radiates towards the axilla. What are the maneuvers that can increase the intensity of mitral regurgitation? Mitral regurgitation is enhanced by maneuvers that increase the TPR, such as squatting or hand grip, as well as conditions that increase the left atrium return, such as an expiration. What are some of the conditions that can lead to mitral regurgitation? Mitral regurgitation can happen due to ischemic heart disease, mitral valve prolapse, or left ventricle dilation. Describe the area where tricuspid regurgitation is heard the best. Tricuspid regurgitation is loudest at the tricuspid area and it radiates towards the right sternal border. What maneuvers enhances the sounds caused by tricuspid regurgitation? Sounds caused by tricuspid regurgitation is enhanced by maneuvers that increase right atrium return, such as an inspiration. What condition can lead to tricuspid regurgitation? Tricuspid regurgitation can be caused by right ventricle dilation. What are some of the conditions that can cause mitral regurgitation or tricuspid regurgitation? Rheumatic fever and infective endocarditis can cause either mitral regurgitation or tricuspid regurgitation. Define hollow systolic. Hollow systolic means something that lasts the entire systole. So basically, hollow systolic murmur is a murmur that you could hear during the entire systole. Heart murmurs. Aortic stenosis. Describe the murmur caused by aortic stenosis. Aortic stenosis causes a crescendo-decrescendo systolic ejection murmur that happens after an ejection click, and the ejection click is something that happens due to abrupt halting of the valve leaflets. What does crescendo-decrescendo mean? Crescendo means loud sound or something that's increasing in intensity. Decrescendo means decreasing intensity or softer sound. So basically it's loud to soft sound, and this happens in the fashion where it's first increasing followed by a decrease in the intensity. So that's why this murmur is referred to as crescendo-decrescendo systolic ejection murmur. One thing to note about aortic stenosis is that the left ventricle is going to have a much higher pressure than the aorta is going to. The reason for this is that the left ventricle must work much harder in order to get the volume out against a stenosed aortic valve. What is pulsus pravus et tardus that happens in aortic stenosis? Pulsus pravus et tardus means that pulses are weak with a delayed peak. This happens in aortic stenosis. The reason for this is that the ventricles of the heart are working hard. There is much higher pressure there, so the heart beats are much loud, but then when you feel the pulses, they're weak because there's not that much blood that's going to the aorta. Therefore, the pulses are much weaker than the sound of the heart itself. What are some of the symptoms that can arise from aortic stenosis? Aortic stenosis can lead to syncope, which is fainting, angina, and dyspnea on exertion. What is the mnemonic to help you remember the symptoms caused by aortic stenosis? The mnemonics is SAD, S-A-D, which stands for syncope, A for angina, and D for dyspnea on exertion. What are some of the conditions that can lead to aortic stenosis? Aortic stenosis can happen due to age-related calcification of the aortic valve, or bicuspid aortic valve can lead to aortic stenosis. Heart murmurs, ventricular septal defect. Describe the murmur caused by ventricular septal defect. Ventricular septal defect causes a hollow systolic harsh-sounding murmur which is loudest at the tricuspid area, and the murmur's intensity is increased with the hand grip maneuver due to increased afterload. Describe the murmur caused by mitral valve prolapse. Mitral valve prolapse causes a late systolic crescendo murmur with a mid-systolic click. Crescendo means that the intensity is increasing, and the mid-systolic click happens due to sudden tensing of the chordae tendineae. This is the most frequent valvular lesion. It's best heard over the apex, it's loudest at the S2, and it's usually a benign condition. What can mitral valve prolapse predispose you to? Mitral valve prolapse can predispose to infective endocarditis. What are some of the causes of mitral valve prolapse? Mitral valve prolapse can happen due to myxomatous degeneration, rheumatic fever, or chordae rupture. What are the maneuvers that can increase the intensity of murmurs caused by mitral valve prolapse? The murmurs of mitral valve prolapse can be enhanced by maneuvers that decrease the venous return, such as standing or Valsalva maneuver. Diastolic heart murmurs. What are the two diastolic heart murmurs? The two diastolic heart murmurs include aortic regurgitation and mitral stenosis. Describe the murmur caused by aortic regurgitation. Aortic regurgitation can cause an immediate high-pitched blowing diastolic decrescendo murmur, which has a wide pulse pressure. When chronic, patients with this condition can present with bounding pulses and head bobbing. What are some of the conditions that can lead to aortic regurgitation? Aortic regurgitation can happen due to aortic root dilation, bicuspid aortic valve, endocarditis, or rheumatic fever. What maneuver increases the intensity of murmurs caused by aortic regurgitation? The maneuver that causes this is the hand grip maneuver. What decreases the intensity of murmurs caused by aortic regurgitation? Vasodilators decreases the intensity of the murmurs caused by aortic regurgitation. Describe the murmur of mitral stenosis. Mitral stenosis can cause a diastolic murmur that has an opening snap, and the opening snap happens due to an abrupt halt in the leaflet motion in a diastole after a rapid opening due to fusion of the leaflet tips. This murmur is referred to as a delayed rumbling late diastolic murmur. One other thing to note about this is that in mitral stenosis, because of the stenotic mitral valve, the left atrium has a much higher pressure than the left ventricle does during a diastole. What condition can lead to mitral stenosis? Mitral stenosis happens secondary to rheumatic fever. What can happen to the left atrium due to chronic mitral stenosis? Chronic mitral stenosis can result in left atrium dilation. What maneuver increases the intensity of murmurs caused by mitral stenosis? Anything that causes an increase in the left atrium return, such as an expiration, will cause the increase in intensity of the murmurs caused by mitral stenosis. Heart murmurs. Name a condition that causes a murmur that lasts for the entire systole as well as the diastole. The condition that can cause a continuous machine-like murmur is patent ductus arteriosus, which is loudest at the S2. What are some of the conditions that can cause PDA? PDA can be caused by congenital rubella or prematurity. What is the best area to hear the PDA? The PDA can be best heard at the left infraclavicular area. Ventricular action potential. Along with the ventricles, where else does this action potential happen? This type of action potential also happens in the bundle of His and the Purkinje fibers. Briefly describe the picture on page 260 of the ventricular action potential. In this picture, you see two things happening. There is one picture that shows you the action potential, and the second picture shows you the currents and how they flow. So let's briefly just look at what's happening with the currents first. Here you see the sodium coming into the cell, then there is a slight outward current of the potassium going out of the cell. Then you also see the calcium coming into the cell in the same picture. This also shows you the sodium-potassium pump and the sodium-calcium exchanger and the leak currents that are also being shown here. Now, Basing it on what I just mentioned about this current, you could also see the action potential. Now, because of that inflow of the sodium, it causes a depolarization effect to happen, which is represented on the action potential here as phase 0. Then you see that phase 1, which is a slight dip. Now, that dip happens because there is a little bit of the potassium current that's going out. Then that is equalized by the inflow of calcium. So it's countering the effect of the potassium, that inflow of calcium. So that's why you see that plateau phase, which is the phase 2. Then the countering effect of calcium has stopped, and there is an outflow current of the potassium, which causes that phase 3, which is the repolarization. Then finally, after this, you have the phase 4, which is dominated by the potassium going out, and that is your resting potential. What happens in phase 0 of the ventricular action potential? Phase 0 is the rapid upstroke phase. In this phase, the voltage-gated sodium channels open. What is phase 1 of the ventricular action potential? Phase 1 of the ventricular action potential is the initial repolarization phase. In this, there is inactivation of the voltage-gated sodium channel, and voltage-gated potassium channels begin to open. What is phase 2 of the ventricular action potential? Phase 2 of the ventricular action potential is the plateau phase. In this, calcium influx through voltage-gated calcium channels balances the potassium efflux. Calcium influx also triggers the calcium release from the sarcoplasmic reticulum and leads to myocyte contraction. What is phase 3 of the ventricular action potential? Phase 3 of the ventricular action potential is the rapid repolarization phase. There is a massive potassium efflux due to opening of the voltage-gated slow potassium channel and closure of the voltage-gated calcium channels. What is phase 4 of the ventricular action potential? Phase 4 of the ventricular action potential is the resting potential. Here there is high potassium permeability through the potassium channels. What are all the differences between the ventricular action potential compared to the skeletal muscle? Cardiac muscle action potential has a plateau, which is due to the calcium influx and the potassium efflux. Myocyte contraction occurs due to calcium-induced calcium release from the sarcoplasmic reticulum. The second difference is that the cardiac nodal cells spontaneously depolarize during a diastole, resulting in automaticity due to IF channels, which are the funny current channels responsible for a slow mixed sodium-potassium inward current. And the third difference is that the cardiac myocytes are electrically coupled to each other by gap junctions. Pacemaker action potential. Where does the pacemaker action potential occur? Pacemaker action potential occurs in the SA and the AV nodes. What is phase 0 of the pacemaker action potential? Phase 0 is the upstroke when the opening of the voltage-gated calcium channel happens. A few things to note about the phase 0 is that fast voltage-gated sodium channels are permanently inactivated because of the less negative resting voltage of these cells. This results in a slow conduction velocity that is used by the AV nodes to prolong the transmission from the atria to the ventricles. Use picture on page 260 to help you answer these questions. Is there a phase 2 or plateau in pacemaker action potential? In pacemaker action potential, the plateau is absent. Describe what happens at phase 3 in pacemaker action potential. In phase 3 pacemaker action potential, there is inactivation of the calcium channels and an increase in activation of the potassium channels. This results in potassium efflux. Describe the phase 4 of the pacemaker action potential. In phase 4, there is slow diastolic depolarization. Membrane potential spontaneously depolarizes as the sodium conduction increases, and this is what accounts for that automaticity of the SA and the AV nodes. The slope of which phase of the pacemaker action potential determines the heart rate. Slope of phase 4 in the SA node determines the heart rate. What drugs affect the pacemaker action potential to decrease the rate of diastolic depolarization and to decrease heart rate? The drugs that decrease the rate of diastolic depolarization and heart rate are ACH and adenosine. What drugs increase the rate of diastolic depolarization and increase heart rate? The drugs that do this is catecholamines. One additional thing to note here is that the sympathetic stimulation increases the chance that the IF channels are open and therefore will increase the heart rate. Based on the picture on page 260 of the pacemaker action potential, briefly describe the difference between pacemaker action potential and the ventricular action potential. In pacemaker action potential, the phase 0 is where there is upstroke that happens, and this happens due to voltage-gated calcium channels, whereas in ventricular action potential, phase 0 is the rapid upstroke that happens due to sodium channel opening. In pacemaker action potential, there is no phase 1 and there is no phase 2. The reason there is no phase 2 is because there is no plateau in pacemaker action potential. In phase 3, there is an efflux of potassium in both ventricular action potential as well as in pacemaker action potential. And finally, in phase 4, there is a slow diastolic depolarization in the pacemaker action potential, and this happens due to increase in sodium conductance, which is much different than what happens in phase 4 of the ventricular action potential, which is the resting potential. Electrocardiogram. Briefly look at the picture on page 261 of the heart. Here you see the aorta, the superior vena cava, the sinoatrial node, internodal pathway, the atrioventricular node, bundle of His, right bundle branch, Purkinje system, left posterior fascicle, left anterior fascicle, and the left bundle branch. To answer the following questions, please refer to the picture on page 261 of the ECG. In an ECG, what does the P wave stand for? The P wave is the atrial depolarization. When does atrial repolarization happen? Atrial repolarization is masked by QRS complex. What is the PR interval? PR interval is the conduction delay through the AV node. What is the normal conduction delay through the AV node? The normal conduction delay through the AV node is less than 200 milliseconds. What is the QRS complex? The QRS complex is ventricular depolarization. How long does the QRS complex last? QRS complex lasts less than 120 milliseconds. What is the QT interval? QT interval is the mechanical contraction of the ventricles. What is the T wave? T wave is the ventricular repolarization. What does T wave inversion indicate? T wave inversion indicates a recent MI. What is the ST segment? ST segment is an isoelectric point when the ventricles are depolarized. What causes the U wave? U wave is caused by hypokalemia and bradycardia. List the part of the heart by their speed of conductance from the fastest to the slowest. Purkinje fibers are the fastest, followed by the atria, followed by the ventricles, followed by the AV node. List the pacemakers from highest to the lowest. The pacemakers are SA node, followed by the AV, followed by the His, Purkinje, as well as the ventricles. Describe the conduction pathway in order. The conduction goes to the SA node, then to the atria, followed by the AV node, then to the common bundle, then to the bundle branches, then to the Purkinje fibers, and finally to the ventricles. One thing to note about the SA node is that they are the pacemakers that inherit dominance with slow phase of upstroke. And in AV node there is a 100 millisecond delay, which is the atrioventricular delay, which allows time for ventricular filling.
What is torsades de pointe? Torsades de pointe is a ventricular tachycardia. What is the characteristic of torsades de pointe? Torsades de pointe is characterized by a shifting sinusoidal waveform on the ECG. What can torsades de pointe progress into? Torsades de pointe can progress into ventricular fibrillation. What is a sign on the ECG that can predispose you to torsades de pointe? The sign on the ECG is that anything that prolongs the QT interval can predispose you to torsades de pointe. What is one of the treatment for torsades de pointe? One of the treatment for torsades de pointe includes magnesium sulfate. What are some of the conditions that leads to congenital long QT syndrome? Some of the conditions that leads to congenital long QT syndrome are most often due to defects in the cardiac sodium or the potassium channel. What is Jarvell and Lang-Nielsen syndrome? Jarvell and Lang-Nielsen syndrome is a type of long QT syndrome which causes the cardiac muscle to take longer than usual to recharge between beats. If untreated, the irregular beats called arrhythmias can lead to fainting, seizures, and even sudden death. This disorder also contributes to hearing loss. ECG tracings, atrial fibrillation. Describe atrial fibrillation from an ECG. In an atrial fibrillation, you see a chaotic and an erratic baseline, irregularly irregular with no discrete P waves in between irregularly spaced QRS complexes. What can be the end result of atrial fibrillation? Atrial fibrillation can result in atrial stasis, which means the flow of blood will stop, and this can lead to a stroke. What are some of the treatment options for atrial fibrillation? The treatment includes rate control, anticoagulation, and possible cardioversion. What is cardioversion? Cardioversion is a medical procedure in which an abnormally fast heart rate or cardiac arrhythmia is converted to normal rhythm. ECG tracings, atrial flutter. What is atrial flutter?
Atrial flutter is a rapid succession of identical back-to-back atrial depolarization waves. Describe the appearance of atrial flutter. Atrial flutter, because of the identical appearance of the waves, it can lead to a sawtooth appearance of the flutter waves. What are some of the treatment options for atrial flutter? Some of the treatment options is pharmacologic conversion to sinus rhythm using class 1A, 1C, and 3 anti-arrhythmics, also rate control using beta blockers or calcium channel blockers. ECG tracings, ventricular fibrillation. What is ventricular fibrillation? Ventricular fibrillation is a completely erratic rhythm with no identifiable waves. What can be the end result of ventricular fibrillation? The end result of a ventricular fibrillation can be a very fatal arrhythmia. What is the immediate treatment option for ventricular fibrillation? To treat ventricular fibrillation immediately, you would need to give CPR as well as defibrillation. AV block, first degree. What is first degree AV block? The first degree AV block is where the PR interval is prolonged more than 200 milliseconds. What are some of the symptoms of first degree AV block? First degree AV block is generally asymptomatic. What are some of the second degree AV block? Second degree AV block, there are two different AV blocks. One is called Morbitz type 1 and the second one is called Morbitz type 2. And both of these are known as the second degree AV block. Morbitz type 1, another name for this, is also Wenckebach. What is Wenckebach Morbitz type 1 second degree AV block? Morbitz type 1 second degree AV block, also known as Wenckebach, is a progressive lengthening of the PR interval until a beat is finally dropped. What this means by the beat being dropped is there's not going to be a QRS complex. What are some of the symptoms of second degree AV block, the Morbitz type 1 Wenckebach? The symptoms of Wenckebach Morbitz type 1 second degree AV block is that it's generally asymptomatic. What is Morbitz type 2 second degree AV block? Morbitz type 2 second degree AV block is when there is a beat drop that are not preceded by a change in the length of the PR interval, which happens in Morbitz type 1. And these abrupt, non-conducted P waves results in a pathological condition. This is generally found as a 2-to-1 block where there is 2 or more P waves for one QRS response. What can Morbitz type 2 progress into? Morbitz type 2 can progress into third degree block. What is the treatment for Morbitz type 2 second degree AV block? Morbitz type 2 second degree AV block can be treated with pacemakers. What is the third degree AV block, also known as the complete AV block? Third degree AV block is when the atria and the ventricles beat independently of each other. Both P waves and QRS complex are present, but in this condition the P waves bears no relations to the QRS complexes. So in this, the P can come at whatever interval it wants, whatever time it wants. So P can be on top of a T wave, or P can be on top of a ST and T complex. So it can happen at any time, because there is no relation between the two. In the third degree AV block, which rate is faster, the atrial or the ventricular? In the third degree complete AV block, the atrial rate is faster than the ventricular rate. What is the treatment for third degree complete AV block? The treatment for third degree complete AV block is pacemakers. What are some of the diseases that can lead to third degree AV block? Diseases such as Lyme disease can result in third degree heart block. Atrial natriuretic peptide. Where and why is atrial natriuretic peptide released from? ANP is released from the atrial myocytes in response to increased blood volume and atrial pressure. This high levels of blood volume and atrial pressure will lead to a generalized vascular relaxation, and this also leads to decrease in sodium reabsorption at the kidney medullary collecting tubule. It constricts the efferent renal arterioles and dilates the afferent arterioles, which is CGMP mediated. So in this way it promotes diuresis and it contributes to the escape from aldosterone mechanism. So the basic job of ANP is to decrease the eventual blood volume and decrease the atrial pressure. Baroreceptors and chemoreceptors. What nerve does the receptors of the aortic arch transmit through? Aortic arch transmits via the vagus nerve to the solitary nucleus of the medulla. Additional note about the aortic arch is that it responds only to increase in blood pressure.
What nerve does the carotid sinus transmit through? The carotid sinus transmits via the glossopharyngeal nerve to the solitary nucleus of the medulla, and a note about this is that it responds to decrease and increase in blood pressure. Describe the function of baroreceptors in response to hemorrhage. In hemorrhage, you would have severe hypotension. This would lead to decrease in arterial pressure. So since the pressure in the arteries is going to be low, this would mean the stretch of the aorta and other arteries would be decreased. This would lead to decrease in afferent baroreceptor firing and would increase the efferent sympathetic firing and decrease the efferent parasympathetic stimulation, which makes sense because due to hypotension, severe hypotension, you would have an increase in flight or fight response and decrease in the rest and digest response. And this would cause vasoconstriction, increase in heart rate, increase in contractility, and eventual increase in blood pressure. What is the carotid massage? Carotid massage is when a physician can massage the carotid artery, and this would cause the increased pressure on the carotid artery. This would lead to increase in stretch, increase in the afferent baroreceptor firing, and this would cause the heart rate to decrease. What is Cushing's reaction? Cushing's reaction is a triad of hypertension, bradycardia, and respiratory depression. How does the baroreceptors contribute to Cushing reaction? The way baroreceptors contribute to Cushing reaction is that when there is an increase in intracranial pressure, it would constrict the arterioles. This would lead to a cerebral ischemia, and in response to this, there would be a reflex sympathetic increase in perfusion pressure. This would lead to hypertension. In hypertension, it would lead to increase in the stretch of the arteries. This would lead to a reflex baroreceptor-induced bradycardia. So this is how baroreceptors can contribute to the Cushing reaction. How are the peripheral chemoreceptors stimulated? The peripheral chemoreceptors at the carotid and the aortic bodies are stimulated by the decrease in PO2 if it gets less than 60 mmHg. They are also stimulated with increase in pCO2, and they are also stimulated in decrease in pH of the blood. How are the central chemoreceptors stimulated? The central chemoreceptors are stimulated by the changes in the pH and the changes in the pCO2 of the brain's interstitial fluid, which in turn is influenced by the arterial CO2. What does the central chemoreceptor not directly respond to? The central chemoreceptor does not directly respond to the PO2. Circulations through the organs. Describe the circulation of blood through the lung. Lung is an organ with the largest blood flow. It has 100% of the cardiac output that goes there. Describe the blood circulation through the liver. The liver gets the largest share of systemic cardiac output. Describe the circulation of blood through the kidney. The kidney has the highest blood flow per gram of tissue. Describe the circulation of blood through the heart. The heart has the largest arteriovenous oxygen difference because the oxygen extraction by the body is around 80%. Therefore, the increase in oxygen demand is met by increase in coronary blood flow, not by increase in extraction of oxygen. Normal pressures in different areas of the heart. What is the normal pressure at the left ventricle? The normal pressure of the left ventricle is 130/10. What is the normal pressure of the right ventricle? The normal pressure of the right ventricle is 25/5. What is the normal pressure at the right atrium? The normal pressure at the right atrium is less than 5. What is the normal pressure at the pulmonary artery? The normal pressure at the pulmonary artery is 25/10. What is the normal pressure at the aorta? The normal pressure at the aorta is 130/90. What is the normal pressure at the left atrium? Normal pressure at the left atrium is less than 12. The pulmonary capillary wedge pressure, PCWP, is also a good approximation of what? The pulmonary capillary wedge pressure is a good approximation of the left atrial pressure, which is about 12 in normal conditions. What happens to pulmonary capillary wedge pressure in conditions such as mitral stenosis? In conditions such as mitral stenosis, the pulmonary capillary wedge pressure is increased much higher than the left ventricular diastolic pressure. What is used to measure the pressures of the heart? The pressure of the heart is measured with the pulmonary artery catheter, also known as the Swan-Ganz catheter.
Autoregulation. What is autoregulation? Autoregulation is how blood flow to an organ remains constant over a wide range of perfusion pressures. What are some of the factors determining autoregulation of the heart? The factors determining the autoregulation of the heart includes local metabolites, which are the vasodilatory metabolites such as carbon dioxide, adenosine, and nitric oxide. What are the factors for determining autoregulation of the brain? The factors that are responsible for autoregulating in the brain are local metabolites, which are also vasodilatory, such as carbon dioxide and pH. What are the factors for determining autoregulation of the kidney? The factor for determining autoregulation of the kidney are myogenic and tubuloglomerular feedback. What are the factors for determining autoregulation of the lungs? The factors that determine autoregulation is that hypoxia causes vasoconstriction in the lungs, which is different from everywhere else because hypoxia everywhere else causes vasodilation. Only in the lungs it causes vasoconstriction. And the reason for this is to allow only well-ventilated areas to be perfused. What are some of the factors for determining autoregulation of the skeletal muscle? The factors for determining autoregulation of the skeletal muscle are local metabolites such as lactate, adenosine, and potassium. What are some of the factors for determining autoregulation of the skin? The factor for determining autoregulation of the skin is sympathetic stimulation for temperature control. Capillary fluid exchange. What are Starling forces? Starling forces are forces that determine fluid movement through the capillary membrane. What does the capillary pressure, also known as PC, do to the fluid? The capillary pressure pushes the fluid out of the capillary. What does the interstitial fluid pressure, also known as the PI, do to the fluid? The interstitial pressure, also known as PI, pushes the fluid into the capillary. What does the plasma colloid osmotic pressure, also known as Pi-C, do to the fluid? The plasma colloid osmotic pressure, also known as Pi-C, pulls fluid into capillary. What does the interstitial fluid colloid osmotic pressure, known as Pi-I, do to the fluid? The interstitial fluid colloid osmotic pressure, Pi-I, pulls the fluid out of the capillary. So you can also think of the colloid osmotic pressure as the attraction pressure, so it pulls towards it. What is the equation of net filtration pressure? The equation for net filtration pressure is P net equals, you first take the capillary pressure and you subtract that with the interstitial fluid pressure. Secondly, you take the plasma colloid osmotic pressure and you subtract that with the interstitial fluid colloid osmotic pressure. Whatever answer you get for the first part, you subtract that with the second part, and that will give you the P net. What is the filtration constant, also known as the Kf? The filtration constant is the capillary permeability, which is a constant. What is the equation for the net fluid flow, also known as the JV? The net fluid flow is the filtration constant times the P net, which is the net filtration pressure. Where is the fluid building up in conditions such as edema? In conditions such as edema, the fluid is collecting in the interstitium. What are some of the conditions that would lead to edema? Edema is caused by conditions that increases the capillary pressure. This would mean that fluid is pushed out of the capillary into the interstitium, and this happens in conditions such as heart failure. It also can happen when there is decrease in the amount of plasma protein, and this is a condition when there would be a decrease in the plasma colloid osmotic pressure. This happens in conditions such as nephrotic syndrome and liver failure, and what's happening here is the pull of the capillary is going down. So it's not attracting enough fluid back into the capillary. That means there's going to be more fluid into the interstitium, and therefore there would be edema built up in the interstitium. Edema can also build up in conditions which leads to increase in capillary permeability. That means that the filtration constant will increase, and this happens in conditions such as toxins, infections, or in burns. You can also have edema built up in conditions where there is an increase in the interstitial fluid colloid osmotic pressure, which means that the interstitium is going to pull more fluid out of the capillary into the interstitium, and this happens in conditions such as lymphatic blockage. Congenital heart disease. Right to left shunt.
What type of cyanosis is right to left shunt usually considered? Right to left shunt is considered early cyanosis, and that's why babies that are born with this condition are termed blue babies. Name the 5 right to left shunts. The 5 right to left shunts are Tetralogy of Fallot, transposition of great vessels, persistent truncus arteriosus, tricuspid atresia, total anomalous pulmonary venous return, TAPVR. What is the mnemonics to help you remember right to left shunt? The mnemonics is the 5 T's, which stands for tetralogy, transposition, truncus, tricuspid, and TAPVR. So these are the 5 right to left shunt that leads to early cyanosis. Of the 5 right to left shunts we've mentioned, which one is the most common cause of early cyanosis? The most common cause of early cyanosis is Tetralogy of Fallot. What is persistent truncus arteriosus? Persistent truncus arteriosus is a condition when there is a failure of truncus arteriosus to divide properly into pulmonary trunk and the aorta. What is another condition that commonly accompanies persistent truncus arteriosus? A condition that commonly accompanies persistent truncus arteriosus is VSD, which is ventricular septal defect. What is tricuspid atresia? Tricuspid atresia is a condition that's characterized by the absence of tricuspid valve and there is a hypoplastic right ventricle. Define the word hypoplastic. Hypoplastic means underdevelopment of an organ because of the decrease in the number of cells. What is required for viability in tricuspid atresia? For viability in tricuspid atresia, you are required to have a ASD, which is atrial septal defect, as well as a VSD, which is ventricular septal defect. Describe what happens in a total anomalous pulmonary venous return, also known as TAPVR. In a TAPVR, the pulmonary vein drains into the right heart circulation, such as at the level of superior vena cava or the coronary sinus. Associated with ASD or sometimes PDA to allow for right to left shunting to maintain cardiac output. Congenital heart disease. Left to right shunts. What kind of cyanosis are the left to right shunts? Left to right shunts are known as late cyanosis, and this leads to blue kids because it happens later in life. What is the most common congenital cardiac anomaly? The most common congenital cardiac anomaly is VSD, which is the ventricular septal defect. What are some of the features of ASD, which is known as the atrial septal defect? Some of the features of ASD includes a loud S1, wide and fixed split S2. What NSAID can you use to close the PDA, which is the patent ductus arteriosus? To close the PDA, you could give the NSAID indomethacin. Name the left to right shunt from most common to the least common. The most common left to right shunt is VSD, followed by ASD, followed by PDA. Eisenmenger syndrome. What is Eisenmenger syndrome? In Eisenmenger syndrome, what happens is because of the uncorrected VSD, ASD, or PDA, to compensate for this left to right shunt, there will be pulmonary vascular hypertrophy, which will result in progressive pulmonary hypertension. As pulmonary resistance increases, the shunt reverses from left to right into right to left, which causes late cyanosis. What are some of the symptoms of Eisenmenger syndrome? Some of the symptoms of Eisenmenger syndrome includes clubbing and polycythemia. What is polycythemia? Polycythemia is a condition in where there is an abnormally increased concentration of hemoglobin or red blood cells in the blood. Tetralogy of Fallot. What is the cause of getting Tetralogy of Fallot? Tetralogy of Fallot is caused by the anterior-superior displacement of the infundibular septum. What are the 4 tetralogies of Tetralogy of Fallot? The 4 things, which means tetralogy, is pulmonary infundibular stenosis, right ventricular hypertrophy, overriding aorta, and ventricular septal defect. These are the 4 things that happen in Tetralogy of Fallot. What is the mnemonics to help you remember the 4 things that happens in Tetralogy of Fallot? The 4 things is the mnemonics PROVE, and that's P for pulmonary infundibular stenosis, R is for right ventricular hypertrophy, O is for the overriding aorta, and V is for ventricular septal defect. What is the most important determinant for prognosis for Tetralogy of Fallot?
The most important determinant for prognosis is the pulmonary infundibular stenosis. Describe the TET spells of Tetralogy of Fallot, as well as why VSD in Tetralogy of Fallot is actually a right to left shunt instead of a left to right shunt. Early cyanosis TET spells is caused by right to left shunt across the VSD. In conditions where there is only a VSD, the flow is usually left to right, which is acyanotic, but in tetralogy, pulmonary stenosis forces the right to left cyanotic flow and causes the right ventricular hypertrophy. Describe the appearance of the right ventricular hypertrophy that you can see on the X-ray. The physical appearance of the right ventricular hypertrophy looks like a boot-shaped heart. Describe how squatting helps in Tetralogy of Fallot. Older patients in tetralogy often learn to squat to reduce the cyanotic symptoms. Squatting actually reduces the blood flow to the legs, which increases the peripheral vascular resistance, the PVR, and thus decreases the cyanotic right to left shunt across the VSD. What is the treatment for Tetralogy of Fallot? The treatment for Tetralogy of Fallot is to treat it early with primary surgical correction. Transposition of the great vessels. Describe what all happens in transposition of great vessels. In transposition of great vessels, the aorta leaves the right ventricle anteriorly and the pulmonary trunk leaves the left ventricle posteriorly. So these two things are just switched over, where the aorta normally leaves the left ventricle, but instead now it's leaving the right ventricle. This transposition leads to the separation of the systemic and pulmonary circulation. So all the deoxygenated blood that's coming back to the heart gets back into the circulation instead of going to the lungs, and all the oxygenated blood that's coming from the lungs goes back to the lungs to get reoxygenated. So it's basically a useless process. This transposition is not compatible with life unless there is a shunt to allow adequate mixing of the blood, such as a ventricular septal defect, a patent ductus arteriosus, or a patent foramen ovale. What is the embryologic reason for the transposition of great vessels? Transposition of the great vessels happens due to the failure of the aortico-pulmonary septum to spiral. What is the treatment option for transposition of great vessels? In transposition of great vessels, surgery is required because without surgery, most infants die within the first few months of life. Coarctation of the aorta. What can happen due to coarctation of the aorta? Coarctation of the aorta can result in aortic regurgitation. What is the infantile type of coarctation of the aorta? The infantile type is where the aortic stenosis happens proximal to the insertion of the ductus arteriosus. So this happens preductally, and this is known as the infant type. What condition is associated with the infantile type of coarctation of the aorta? Infantile type of coarctation of the aorta is associated with Turner syndrome. What is the mnemonics to help you remember infantile type coarctation of the aorta? The mnemonics to help you remember is infantile, which has the word in it, which means that it's in close to the heart. So it's closer to the heart, and this is the infantile type. What should you do in a physical exam to detect infantile type of coarctation of the aorta? In infantile type of coarctation of the aorta, you would want to check the femoral pulse. What is adult type coarctation of the aorta? Adult type coarctation of the aorta is when the stenosis is distal to the ligamentum arteriosum, which means it's postductally. What are some of the conditions that would result from adult type coarctation of the aorta? In adult type coarctation of the aorta, it would lead to notching of the ribs, and this happens due to the collateral circulation. It would also lead to hypertension in the upper extremities and weak pulses in the lower extremities compared to the upper. What is the mnemonics to help you remember adult type coarctation of the aorta? The mnemonics to help you remember this is that the word adult has a D in it, and in adult type coarctation of the aorta, coarctation is located distal to the ductus. Adult type coarctation of the aorta is most commonly associated with what type of valve condition? Adult type coarctation of the aorta is most commonly associated with a bicuspid aortic valve. Patent ductus arteriosus. Describe what is patent ductus arteriosus. In fetal period, there is a shunt that happens right to left, which is a normal condition. So there is blood that goes from aorta to the pulmonary artery, and this is a normal situation in the fetal period. Now, in neonatal period, lung resistance decreases and shunt becomes left to right with subsequent right ventricular hypertrophy and or left ventricular hypertrophy and failure. This is an abnormal situation. What kind of murmur is heard with a patent ductus arteriosus? Patent ductus arteriosus is associated with a continuous machine-like murmur. What drugs allow you to keep the patent ductus arteriosus open? Patency is maintained by prostaglandin synthesis and low oxygen tension. What NSAID can help you close the patent ductus arteriosus? The drug that can help you close the PDA is indomethacin. A note about patent ductus arteriosus is that PDA is normal in utero but normally closes after birth. What happens if a PDA is not corrected? Uncorrected PDA can eventually result in late cyanosis in the lower extremities.
Congenital cardiac defect associations. What are some of the congenital cardiac defects associated with 22q11 syndrome? Some of the congenital cardiac defects associated with 22q11 syndrome includes truncus arteriosus and Tetralogy of Fallot. What are some of the congenital cardiac defects associated with Down syndrome? Some of the congenital cardiac defects associated with Down syndrome includes ASD, VSD, AV septal defect, which is the endocardial cushion defect. What are some of the congenital cardiac defects associated with congenital rubella? Some of the congenital cardiac defects associated with congenital rubella include septal defect, PDA, and pulmonary artery stenosis. What is a congenital cardiac defect associated with Turner syndrome? A congenital cardiac defect associated with Turner syndrome is the coarctation of the aorta, which happens preductally. What is a congenital cardiac defect associated with Marfan syndrome? A congenital cardiac defect associated with Marfan syndrome is aortic insufficiency and dissection, which happens as a late complication. What is a congenital cardiac defect associated with infant of a diabetic mother? A congenital cardiac defect associated with infant of a diabetic mother is transposition of great vessels. Hypertension. What is hypertension? Hypertension is a condition when the blood pressure is greater than or equal to 140/90 millimeters of mercury. What are some of the risk factors of getting hypertension? Some of the risk factors of getting hypertension includes increase in age, obesity, diabetes, smoking, genetics-related factor. Blacks have a higher rate of getting hypertension, followed by white people, and then followed by Asians. What are some of the features of hypertension? Some of the features of hypertension is that 90% of hypertension is primary, which is the essential hypertension, and it's related to increase in cardiac output or increase in total peripheral resistance. Remaining 10% is mostly secondary, and this is caused by renal disease. What is malignant hypertension? Malignant hypertension is a more severe type of hypertension in which there is a greater blood pressure of 180/120 millimeters of mercury and is rapidly progressing. What are some of the conditions that hypertension can predispose you to? Hypertension can predispose you to getting atherosclerosis, left ventricular hypertrophy, increases the chance of getting a stroke, congestive heart failure, renal failure, retinopathy, and aortic dissection. Hyperlipidemia signs. What is atheromas? Atheromas is a condition when there is plaques in the blood vessel wall. What are xanthomas? Xanthomas are plaques or nodules composed of lipid-laden histiocytes in the skin, especially around the eyelids, which are known as xanthelasmas. What are tendinous xanthoma? Tendinous xanthoma is lipid deposit in tendon, especially it happens in the Achilles tendon. What is corneal arcus? Corneal arcus is a lipid deposit in the cornea. What is arcus sinalis? Arcus sinalis is a white, gray, or a blue opaque ring in the corneal margin. Arteriosclerosis. What is Mönckeberg arteriosclerosis? Mönckeberg arteriosclerosis is the calcification in the media of the arteries, especially radial or ulnar arteries. Is Mönckeberg arteriosclerosis a benign or a malignant condition? Mönckeberg arteriosclerosis is a benign condition. Describe some of the key characteristics of Mönckeberg arteriosclerosis. Some of the key characteristics of Mönckeberg arteriosclerosis is that it's referred to as pipestem arteries, it does not obstruct blood flow, and the intima of the arteries is not involved. What are the two types of arteriolosclerosis? The two types of arteriolosclerosis is hyaline and a hyperplastic arteriolosclerosis. What is hyaline type of arteriolosclerosis? The hyaline type of arteriolosclerosis is when there is thickening of small arteries, and it happens in conditions such as essential hypertension or diabetes mellitus. Describe the hyperplastic type of arteriolosclerosis. The hyperplastic type of arteriolosclerosis is when there is onion skinning appearance of the arteries, which happens in malignant hypertension. What is atherosclerosis? Atherosclerosis is a condition in which fibrous plaque and atheromas form in the intima of the arteries.
Atherosclerosis. What is atherosclerosis? Atherosclerosis is a disease of elastic arteries and large and medium-sized muscular arteries. What are some of the modifiable risk factors of getting atherosclerosis? Some of the modifiable risk factors of getting atherosclerosis include smoking, hypertension, hyperlipidemia, and diabetes. What are some of the non-modifiable risk factors of getting atherosclerosis? Some of the non-modifiable risk factors include age, gender, and it's a higher risk in men and postmenopausal women, as well as positive family history. Describe how progression happens in atherosclerosis. The progression can happen with the start of inflammation, which is important for pathogenesis as it can start the pathogenesis. Endothelial cell dysfunction will lead to macrophage and LDL accumulation. This will then result in foam cell formation. There's also then going to be fatty streak. There is smooth muscle cell migration, which involves platelet-derived growth factor and fibroblast growth factor. Then there would be proliferation of this and extracellular matrix deposition. Then this would lead to fibrous plaque formation. And then finally, a complex atheroma formation will happen. What are some of the complications that can arise from atherosclerosis? Some of the complications that can arise includes aneurysm formation, ischemia, infarcts, peripheral vascular disease, thrombus, and an emboli formation. Name the locations in order for the most common to the least common of where atherosclerosis can form. The most common area where atherosclerosis can form is abdominal aorta, followed by the coronary artery, followed by the popliteal artery, and followed by the carotid artery. What are some of the symptoms of atherosclerosis? Some of the symptoms of atherosclerosis include angina, claudication, and in some cases it could be asymptomatic. Define claudication. Claudication is a condition in which cramping pain in the leg is induced by exercise, typically caused by obstruction of the arteries.
Aortic aneurysms. What is aortic aneurysms? Aortic aneurysms is a localized pathologic dilation of the blood vessels. What condition is associated with abdominal aortic aneurysm? Abdominal aortic aneurysm is associated with atherosclerosis. What group of patient does abdominal aortic aneurysm most commonly affect? Abdominal aortic aneurysm most commonly occurs in hypertensive male smokers over the age of 50. What are some of the conditions associated with thoracic aortic aneurysm? Some of the conditions associated with thoracic aortic aneurysm includes hypertension, cystic medial necrosis, which happens in Marfan syndrome, and tertiary syphilis. Aortic dissection. What is aortic dissection? Aortic dissection is a longitudinal intraluminar tear forming a false lumen. What are some of the conditions that predisposes you to aortic dissection? Some of the conditions that predisposes you to aortic dissection includes hypertension, bicuspid aortic valve, cystic medial necrosis, and inherited connective tissue disorder such as Marfan syndrome. What would be a major complaint of a patient that is suffering from aortic dissection? A major complaint of a patient suffering aortic dissection would be tearing chest pain radiating to the back. What would you see on a chest x-ray in a patient suffering aortic dissection? In a chest x-ray of a patient suffering aortic dissection, you would see mediastinal widening. What are some of the eventual consequences of aortic dissection? Aortic dissection can lead to pericardial tamponade, aortic rupture, and death.
Ischemic heart disease manifestation. What is angina? Angina is a condition that is marked by severe chest pain in the chest, which happens due to the narrowing of the coronary arteries. And this happens when the narrowing is more than 75%. But there is no myocyte necrosis. What is stable angina? Stable angina is retrosternal chest pain with exertion. This happens mostly secondary to atherosclerosis. What are the ECG changes observed in stable angina? In stable angina, there is ST depression on the ECG. What is Prinzmetal's variant angina? Prinzmetal variant angina is chest pain that occurs at rest secondary to coronary artery spasm. What are the ECG changes observed in Prinzmetal angina? In Prinzmetal angina, there is ST elevation on the ECG. What is unstable or crescendo angina? Unstable or crescendo angina is chest pain that happens due to thrombosis with incomplete coronary artery occlusion. What are the ECG changes observed with unstable or crescendo angina? In unstable or crescendo angina, there is ST depression on the ECG. One thing to note about this angina is that there is worsening chest pain at rest or with minimal exertion. What is coronary steal syndrome? Coronary steal syndrome is a phenomenon where the alteration of the circulation pattern leads to reduction in the blood directed to the coronary artery. It is caused when there is a narrowing of the coronary arteries and a coronary vasodilators are used. What this does is there is going to be stealing of blood away from those parts of the heart. This happens as a result of the narrowed coronary arteries always being maximally dilated to compensate for the decreased upstream blood supply. This ends up resulting in resistant vessels of the coronary artery, which causes the blood to be shunted away from the coronary vessels, supplying the ischemic zones, which in turn will create more ischemia. So basically in this condition, vasodilators are what is aggravating ischemia by shunting blood from areas of critical stenosis to an area of higher perfusion. How does myocardial infarction happen? Myocardial infarction happens when there is acute thrombosis due to coronary artery atherosclerosis, which leads to complete occlusion of the coronary artery, and this leads to myocyte necrosis. What are the ECG changes in myocardial infarction? In myocardial infarction, the ECG first shows ST depression. This can progress into ST elevation with continued ischemia and transmural necrosis. What is sudden cardiac death? Sudden cardiac death is death from cardiac causes within 1 hour of onset of symptoms. This happens due to a lethal arrhythmia like ventricular fibrillation and is associated with coronary artery disease in up to 70% of the cases. What does chronic ischemic heart disease eventually lead to? In chronic ischemic heart disease, it eventually will progress into congestive heart failure, and this happens due to chronic ischemic myocardial damage. Evolution of MI. Name the 3 coronary arteries to get occluded from the most common to the least common. The 3 coronary arteries that often get occluded in order starts with LAD is the most common, followed by the RCA, followed by the circumflex. What are some of the symptoms observed in MI? Some of the symptoms of MI includes diaphoresis, which is excessive sweating, nausea, vomiting, severe retrosternal pain, pain in the left arm or the jaw, shortness of breath, and fatigue. What are some of the gross changes of the heart that can be seen from 0 to 4 hours post-MI? In 0 to 4 hours post-MI, there is no gross changes. What are some of the changes in the heart that can be seen under a light microscope from 0 to 4 hours post-MI? In 0 to 4 hours post-MI, there are also no changes visible in light microscopy. What are some of the conditions that can develop from 0 to 4 hours post-MI? In 0 to 4 hours post-MI, there is a higher risk of getting an arrhythmia, also congestive heart failure exacerbation, as well as cardiogenic shock. What are some of the gross changes that are visible 4 to 12 hours post-MI? Some of the gross changes 4 to 12 hours post-MI includes dark mottling, which is pale with tetrazolium stain. What are some of the changes that can be seen under a light microscope 4 to 12 hours post-MI? Some of the changes under light microscope 4 to 12 hours post-MI includes early coagulative necrosis, edema, hemorrhage, and wavy fibers. What is a condition that can arise 4 to 12 hours post-MI? 4 to 12 hours post-MI, there is a higher risk of getting arrhythmias. What are some of the gross changes of the heart 12 to 24 hours post-MI? Some of the gross changes 12 to 24 hours post-MI includes dark mottling, which is pale with tetrazolium stain. What are some of the changes seen under a light microscope 12 to 24 hours post-MI? Some of the changes seen under a light microscope 12 to 24 hours post-MI includes contraction bands from reperfusion injury. There's also going to be a release of necrotic cell content into the blood and beginning of neutrophil migration. What is a condition that can arise 12 to 24 hours post-MI? A condition that can arise 12 to 24 hours post-MI is arrhythmia. What are some of the gross changes that happen in the heart 1 to 3 days after MI? Some of the gross changes that happens 1 to 3 days post-MI includes hyperemia in the area of infarction. What are some of the changes under a light microscope that can be seen 1 to 3 days post-MI? Some of the changes under a light microscope 1 to 3 days post-MI includes extensive coagulative necrosis. There is tissue surrounding the infarct which shows acute inflammation and neutrophil migration. What is a condition that can happen 1 to 3 days post-MI? A condition that can arise 1 to 3 days post-MI is fibrinous pericarditis. What are some of the gross changes of the heart that can happen 3 to 14 days post-MI? Some of the gross changes include formation of a hyperemic border. There would also be central yellow-brown softening, which is maximally yellow and soft by 10 days. What are some of the changes that can be seen under a light microscope 3 to 14 days post-MI? In 3 to 14 days post-MI, you would see macrophage infiltration followed by granulation tissue at the margins. What is a condition that can arise 3 to 14 days post-MI? In 3 to 14 days post-MI, there is a risk of free-walled rupture leading to tamponade, papillary muscle rupture, ventricular aneurysms, interventricular septal rupture due to macrophages that have degraded important structural components. What are some of the gross changes of the heart that will occur 2 weeks to several months post-MI? Some of the gross changes that occur 2 weeks to several months post-MI includes formation of a recanalized artery, and the area of infarction would turn gray to white in color. What are some of the changes of the heart seen under a light microscope from 2 weeks to several months post-MI? Some of the changes under a light microscope 2 weeks to several months post-MI includes the completion of a contracted scar. What syndrome can occur from 2 weeks to several months post-MI? A syndrome that can occur is Dressler's syndrome. What is Dressler's syndrome? Dressler's syndrome is an autoimmune phenomenon that results in fibrinous pericarditis.
Diagnosis of an MI. What is the gold standard in diagnosing MI in the first 6 hours? The gold standard in diagnosing MI in the first 6 hours is ECG, which stands for Electrocardiogram. Describe how cardiac troponin 1 is used to diagnose MI. Cardiac troponin 1 rises after 4 hours and is elevated for 7 to 10 days. This is more specific than other protein markers used to diagnose MI. Describe how CKMB is used to diagnose MI. CKMB is predominantly found in the myocardium, but can also be released from the skeletal muscle. It's useful in diagnosing reinfarction following an acute MI because levels return to normal after 48 hours. Describe some of the changes that can be observed in ECG in helping to diagnose MI. Some of the changes that can be observed in ECG includes an ST elevation, which indicates a transmural infarct. You can also observe a ST depression, which indicates a subendocardial infarct, and you can also observe a pathological Q wave, which also indicates a transmural infarct.
Types of infarcts. What are the 2 types of infarcts? The 2 types of infarcts are transmural infarct and subendocardial infarct. Describe transmural infarct. Transmural infarct is associated with atherosclerosis involving a major coronary artery. It can be subclassified into anterior, posterior, inferior, lateral, or septal. Transmural infarcts extend through the whole thickness of the heart muscle and are usually a result of a complete occlusion of the areas of the blood supply. In addition, on ECG, there is ST elevation and a Q wave are generally seen. One other thing to note here is that in transmural infarct, there is higher amount of necrosis. Describe subendocardial infarct. Subendocardial infarct is an infarct that involves a small area in the endocardial wall of the left ventricle, ventricular septum, or the papillary muscle. The subendocardial area is particularly susceptible to ischemia. In addition, there would be ST depression seen in the ECG. ECG diagnosis of an MI. If the infarct happens at the anterior wall due to occlusion of the left anterior descending artery, which leads would show the Q wave? V1 through V4 would show the Q wave. If the infarct is located at the anteroseptal area due to the effect on the left anterior descending artery, which leads would show the Q wave? Leads V1 through V2 would show the Q waves. If the infarct is located anterolateral due to the occlusion of the left circumflex coronary artery, which leads would show the Q wave? The leads that would show the Q wave would be V4 through V6. If the infarct occurs at the lateral wall due to the occlusion of the left circumflex coronary artery, which leads would show the Q wave? The leads that would show the Q wave is lead 1 and AVL. If the infarct occurs at the inferior wall due to the occlusion of the right coronary artery, which leads would show the Q wave? The leads that would show the Q wave is lead 2, lead 3, and AVF. MI complications. In a patient suffering an MI, what is a complication that can cause death before reaching the hospital? Cardiac arrhythmia can lead to death before the patient reaches the hospital. What is a complication that can arise if a patient has suffered a large infarct? In a patient suffering from a large infarct, it can lead to cardiogenic shock, which has a high risk of mortality. What post-MI complications can lead to cardiac tamponade? Ventricular free wall rupture can lead to cardiac tamponade. What post-MI complication can lead to severe mitral regurgitation? Severe mitral regurgitation can happen due to papillary muscle rupture post-MI. What MI complications can lead to a ventricular septal defect? Ventricular septal defect can arise due to an interventricular septum rupture, which can happen due to an MI. Why is ventricular aneurysm formation an important complication of an MI? In ventricular aneurysm formation, there is decrease in cardiac output. In this, there is also an increased risk of arrhythmia and embolus from mural thrombus. The highest risk of getting ventricular aneurysm happens 1 week post-MI. What can cause a friction rub 1 to 3 days post-MI? A friction rub 1 to 3 days post-MI can happen due to post-infarction fibrinous pericarditis. What is Dressler syndrome? Dressler syndrome is an autoimmune phenomenon resulting in fibrinous pericarditis, which can happen several weeks post-MI.
Cardiomyopathy. What is the most common cardiomyopathy? The most common cardiomyopathy is the dilated congestive cardiomyopathy, which happens in 90% of the cases. What are some of the etiologies of dilated congestive cardiomyopathy? Some of the etiologies include chronic alcohol abuse, wet beriberi, Coxsackie B virus caused myocarditis, chronic cocaine use, Chagas disease, doxorubicin toxicity, hemochromatosis, and peripartum cardiomyopathy. What are some of the clinical findings of dilated congestive cardiomyopathy? Some of the clinical findings includes an S3 that's going to be present. You would also be able to see a dilated heart on ultrasound. There is going to be balloon appearance on chest x-ray. Would a patient suffer systolic or diastolic dysfunction with dilated congestive cardiomyopathy? In dilated congestive cardiomyopathy, there would be systolic dysfunction. Describe the type of hypertrophy that would be observed in dilated congestive cardiomyopathy. In dilated congestive cardiomyopathy, you would see an eccentric hypertrophy because of the sarcomeres that are added in series. What are some of the treatment options for dilated congestive cardiomyopathy? Some of the treatments for dilated congestive cardiomyopathy includes sodium restriction, ACE inhibitors, diuretics, digoxin, and a heart transplant. Cardiomyopathy. What is hypertrophic cardiomyopathy? Hypertrophic cardiomyopathy is a condition that would lead to a hypertrophied interventricular septum, which will result in the interventricular septum being too close to the mitral valve leaflet, and that would lead to an outflow tract obstruction. What type of familial association does hypertrophic cardiomyopathy have? Hypertrophic cardiomyopathy in 60 to 70% of the cases are familial. It's a autosomal dominant condition. Commonly a beta myosin heavy chain mutation will lead to this. Would you observe a diastolic or a systolic dysfunction with hypertrophic cardiomyopathy? In hypertrophic cardiomyopathy, you would be able to observe a diastolic dysfunction. Describe the kind of hypertrophy seen in hypertrophic cardiomyopathy. The kind of hypertrophy you would see is asymmetric concentric hypertrophy, which happens due to sarcomeres added in parallel. Because of the proximity of the hypertrophied interventricular septum to the mitral valve leaflet, what kind of murmurs would you be able to observe? Some of the murmurs that you would be able to observe in this condition is a systolic murmur. What type of ataxia is generally associated with hypertrophic cardiomyopathy? The type of ataxia generally associated with hypertrophic cardiomyopathy is the Friedreich ataxia. Describe the appearance of myocardial fibers in hypertrophic cardiomyopathy. The myocardial fibers in hypertrophic cardiomyopathy appear disoriented, tangled, and hypertrophied. What can be the eventual consequence of hypertrophic cardiomyopathy in young athletes? The eventual consequence of hypertrophic cardiomyopathy in young athletes can be sudden death. What are some of the findings that are observed in hypertrophic cardiomyopathy? Some of the findings of hypertrophic cardiomyopathy includes a normal-sized heart, there is a S4, apical impulses, and a systolic murmur can be heard. What is the treatment for hypertrophic cardiomyopathy? The treatment for hypertrophic cardiomyopathy includes beta blocker or a non-dehydropyridine calcium channel blocker such as verapamil. Restrictive and obliterative cardiomyopathy. What are some of the major causes of restrictive/obliterative cardiomyopathy? Some of the major causes of this include sarcoidosis, amyloidosis, post-radiation fibrosis, endocardial fibroelastosis, Loeffler syndrome, and hemochromatosis. What is endocardial fibroelastosis? Endocardial fibroelastosis is when there is a thick fibroelastic tissue in the endocardium of young children. What is Loeffler syndrome? Loeffler syndrome is a endomyocardial fibrosis with a prominent eosinophilic infiltrate. What is another condition that can also occur in hemochromatosis? Hemochromatosis, along with restrictive/obliterative cardiomyopathy, can also lead to dilated cardiomyopathy. What kind of dysfunction happens in restrictive/obliterative cardiomyopathy? Is it diastolic dysfunction or is it systolic dysfunction? The dysfunction that happens in restrictive obliterative cardiomyopathy is a diastolic dysfunction. Congestive heart failure. What is congestive heart failure? Congestive heart failure is a clinical syndrome that occurs in patients with an inherited or an acquired abnormality of the cardiac structure or the function. What are some of the signs and symptoms of congestive heart failure? Some of the signs of congestive heart failure includes edema and rales. Along with that, some of the symptoms are dyspnea and fatigue. What is rales? Rales is an abnormal rattling sound heard when examining an unhealthy lung. What is the most common cause of getting right-sided heart failure? The most common cause of getting right-sided heart failure is due to left-sided heart failure. What is the cause of an isolated right heart failure? An isolated right heart failure is usually due to cor pulmonale. What is cor pulmonale? Cor pulmonale is a condition where there is an enlargement of the right ventricles of the heart, and this happens due to disease of the lungs or disease of the pulmonary blood vessels. What are some of the drugs that can reduce the mortality rate of patients with congestive heart failure? Some of the drugs that can reduce the mortality rate include ACE inhibitor, beta blocker, except in conditions like acute decompressed heart failure, angiotensin receptor antagonist, and spironolactone. What are some of the drugs that are mainly used for symptomatic relief in congestive heart failure? Some of the drugs used for symptomatic relief in congestive heart failure includes drugs like thiazides or loop diuretics. What are some of the drugs that provide both symptomatic relief as well as decreases the mortality rate in congestive heart failure? The drug that can do both of these things is hydralazine with nitrate therapy. Why does cardiac dilation happen? And why a person would have dyspnea on exertion? What is the reason that will cause the heart to dilate? The cause of cardiac dilation is there is a greater ventricular and diastolic volume. What is the reason that a person would have dyspnea on exertion? The reason for this is the failure of cardiac output to increase during exercise. Left heart failure. What is the reason for pulmonary edema as well as paroxysmal nocturnal dyspnea to happen in a patient with left-sided heart failure? The reason this would happen is because in left-sided heart failure, there would be an increase in pulmonary venous pressure. So the blood that's coming to the heart from the lungs, there would be an increase in pressure in that blood. Now, because of this, this would lead to a pulmonary venous distension, and because of this, it leads to a transudation of fluid. And all this fluid backs up into the lungs, and therefore you would have pulmonary edema and paroxysmal nocturnal dyspnea. What are some of the cells that you would also find in the lungs in a patient with left-sided heart failure? In a patient with left-sided heart failure, you would find hemosiderin latent macrophages, which are known as the heart failure cells, and these would be present in the lungs. Why does orthopnea happen in left-sided heart failure? In left-sided heart failure, the reason you would have orthopnea is because there would be an increase in venous return and supine position, which would exacerbate pulmonary vascular congestion. What is orthopnea? Orthopnea is a condition when there is a shortness of breath when a person is in supine position, so they could only breathe comfortably when they're standing or sitting erect. Right-sided heart failure. Why does hepatomegaly, also known as the nutmeg liver, happen in right-sided heart failure? The reason for this to happen is because there is an increase in the central venous pressure. This leads to an increase in resistance to the portal flow, and so this means that due to right-sided heart failure, the blood has backed up into the liver, and therefore it will cause the hepatomegaly. Why does peripheral edema happen due to right-sided heart failure? The reason for this is there is an increase in the venous pressure. This causes all the blood to back up, and because of all the blood being backed up, the flow is not able to move forward, and when this happens, there would be fluid transudation, and this is why it leads to peripheral edema. Why does jugular venous distension also happen in right-sided heart failure? Again, it's because of the same reason, there being an increase in venous pressure. This leads to jugular venous distension. The picture that you can see here on page 273. Now we're going to start off on the top where it says that due to decrease in the left ventricular contractility, what all happens. So now we're going to start here and we're going to say that due to a decrease in left ventricular contractility, this will lead to a decrease in cardiac output. So if the ventricle is not contracting properly, that means the flow of blood, the cardiac output, is not sufficient, and that's why it shows a decrease in cardiac output. Now, when there is decrease in cardiac output, this means there is going to be less blood flowing to the kidneys, which makes sense because if the blood is not flowing properly out of the heart, if it's not sufficient, that means everywhere in your body there's going to be less blood flow, and therefore in the kidney there's also going to be decrease in blood flow. Now, when the kidney detects that there is decrease in blood flow, it causes the activation of the renin-angiotensin-aldosterone system. Now, that's why you see, because of that activation, the increase in renin-angiotensin-aldosterone system here in the picture. Now, because of this activation, it leads to an increase in renal sodium and water reabsorption. Therefore, because of this reabsorption, it would mean that it's trying to conserve, it's trying to keep more blood in, and because of this, there would be an increase in venous pressure. Now, because of that increase in venous pressure, because you have more volume, because of the retention of the sodium in the water, this would lead to peripheral edema. So that's what happens. That's how you get to peripheral edema, from left ventricular contractility being low. Now, what also happens is, due to decrease in left ventricular contractility, you would also get a pulmonary venous congestion. This leads to pulmonary edema. And because of the pulmonary venous congestion, this also leads to decrease in right ventricular output. And this is another reason why blood would be backed up, and that also can cause
peripheral edema. Now coming back to the other side where it talks about the decrease in cardiac output, now this also leads to increase in the sympathetic activity. That also has an effect on activating the renin-angiotensin-aldosterone system. Also, increase in sympathetic activity will increase the left ventricular contractility. This leads to increase in preload, increase in cardiac output, and this is this is how the heart compensates for the decrease in cardiac output to get the cardiac output to be increased with this sympathetic activity, which is a mechanism that our body uses when it detects a decrease in cardiac output in an attempt to increase that cardiac output. Bacterial endocarditis. What are some of the symptoms of bacterial endocarditis? The symptoms of bacterial endocarditis includes fever, which is the most common symptom. There's also Roth spots, which are round, white spots on the retina surrounded by hemorrhage. So these are the Roth spots. Along with that, there's also Osler's node, which are tender raised lesions on finger and toe pads. There is also a murmur that can be heard in bacterial endocarditis. Janeway lesions, which are small, painless erythromatous lesions on the palms and the sole. There is also anemia, and there are splinter hemorrhages on the nail beds. What is the mnemonics to help you remember all the symptoms of bacterial endocarditis? The mnemonics to help you remember all the symptoms is just remember bacteria from Jane. The most important thing about this mnemonics is to remember that from Jane part. The F stands for fever, the R stands for Roth spots, O stands for Osler's node, M stands for the new murmur, J stands for the Janeway lesions, A stands for anemia, N stands for nail bed hemorrhage, and E stands for emboli. What is the most common valve to be involved in bacterial endocarditis? The valve to be involved most commonly in bacterial endocarditis is the mitral valve. What group of people are more likely to be affected with the tricuspid valve endocarditis? The group of people that are more likely to have tricuspid valve endocarditis is IV drug abusers. What is the mnemonics to help you remember that tricuspid valve are associated with drug abusers? The mnemonics to help you remember this is just remember don't try drugs. The tri for tricuspid valve and drugs, just to help you remember that tricuspid valve endocarditis happens more commonly in IV drug users. What infections will lead to tricuspid valve endocarditis in IV drug abusers? Tricuspid valve endocarditis in IV drug abusers can happen due to Staph aureus, Pseudomonas, and Candida. What are some of the complications that can arise from bacterial endocarditis? Some of the complications is chordae rupture can happen, glomerulonephritis, suppurative pericarditis, and an emboli can form. How do you diagnose bacterial endocarditis? Bacterial endocarditis can be diagnosed after multiple blood cultures. What bacteria most commonly causes acute bacterial endocarditis? Acute bacterial endocarditis is caused by Staph aureus and it has a high virulence. One additional note about acute bacterial endocarditis is that there would be large vegetations on a previously normal valve, as well as this has a rapid onset. What bacteria most commonly causes subacute bacterial endocarditis? The bacteria to cause subacute bacterial endocarditis are the virulent streptococci that have a low virulence. Describe the type of vegetations as well as the onset of subacute bacterial endocarditis. In subacute bacterial endocarditis, there are smaller vegetations on a congenitally abnormal or diseased valve. This can happen in a patient after a dental procedure, and it's a more insidious onset. What are some of the non-bacterial causes of endocarditis? Some of the non-bacterial causes of endocarditis are malignancies, hypercoagulable state can also lead to endocarditis, and in lupus it can happen. What is the cause of endocarditis in patients with colon cancer? In patients with colon cancer, the reason they would get endocarditis is due to strep bovis. What is the cause of endocarditis in patients with prosthetic valve? The reason for endocarditis in patients with prosthetic valve is strep epidermidis. Rheumatic fever. What is the cause of rheumatic fever?
Rheumatic fever can happen after a pharyngeal infection with a group A beta hemolytic streptococci. What is a cause of early death in a patient with rheumatic fever? In a patient with rheumatic fever, the cause of early death is due to myocarditis. What is a late sequela to rheumatic fever? The late sequela to rheumatic fever includes rheumatic heart disease, which affects the valves, and it affects mitral valve most commonly, followed by aortic valve, followed by the tricuspid valve. And the reason for this is the high pressure valves are affected the most. What is a early lesion in rheumatic heart disease? An early lesion in rheumatic heart disease is that there will be mitral valve regurgitation. What is a late lesion in rheumatic heart disease? A late lesion in rheumatic heart disease is mitral stenosis. What are some of the pathophysiological signs of rheumatic heart disease? Some of the pathophysiological signs associated with rheumatic fever includes Aschoff bodies, which are granulomas with giant cells. You would also see Anterschau cells, which are activated histiocytes, and there will also be elevated ASO titers. What does ASO stand for? ASO stands for anti-streptolysin O. What type of hypersensitivity is rheumatic heart disease? Rheumatic heart disease is an immune-mediated type 2 hypersensitivity. What does the body make antibody to that would lead to rheumatic heart disease? Rheumatic heart disease happens due to antibodies to M protein. What are all the signs and symptoms of rheumatic fever? All the signs and symptoms of rheumatic fever are fever, erythema marginatum, valvular damage, which happens due to the vegetation and fibrosis. There would also be an increase in the ESR, which is the erythrocyte sedimentation rate. You would also have red hot joints, which is the migratory polyarthritis, as well as subcutaneous nodules, and St. Virtue's dance, which is the Sydenham's chorea. What is the mnemonics to help you remember all the signs and symptoms of rheumatic fever? The mnemonics is fevers, that's FEVERSS, and that stands for F for fever, E for erythema marginatum, V for valvular damage, E for erythrocyte sedimentation rate, R is for the red hot joints, which is the migratory polyarthritis. The first S is for the subcutaneous nodules, and the second S is for the St. Virtue's dance, which is the Sydenham's chorea. Acute pericarditis. What are some of the common complaints of a patient that's suffering from acute pericarditis? Patients suffering from acute pericarditis commonly presents with sharp pain aggravated by inspiration, and it's relieved by sitting up and leaning forward. They also have friction rub, and this happens because of the inflammation to the pericardium. It would cause a friction rub. What are some of the ECG changes observed with acute pericarditis? Some of the ECG changes includes a widespread ST segment elevation and or a PR depression. Name the three types of acute pericarditis. The three types of acute pericarditis includes fibrinous, serous, and suppurative/purulent acute pericarditis. What are some of the causes of fibrinous acute pericarditis? Some of the causes of fibrinous pericarditis includes Dressler syndrome, uremia, and radiation. What is Dressler syndrome? Dressler syndrome is a secondary form of pericarditis that occurs in the setting of injury to the heart or the pericardium. Pericardium is, of course, the outer lining of the heart. This condition consists of a triad of features such as fever, pleuritic pain, and a pericardial effusion. And this commonly happens post-myocardial infarction. What is a presenting symptom of a patient suffering from fibrinous pericarditis? Fibrinous pericarditis patients presents with a loud friction rub. What are some of the causes of serous acute pericarditis? Some of the causes of serous acute pericarditis are viral pericarditis. There's also non-infectious inflammatory disease that causes serous pericarditis, which includes rheumatoid arthritis, and SLE, which stands for systemic lupus erythematosus. What are some of the causes of suppurative/purulent acute pericarditis? Some of the causes of suppurative/purulent acute pericarditis is bacterial reasons such as with pneumococcus and streptococcus, but this has become very rare now because of antibiotics. Cardiac tamponade. What is cardiac tamponade? Cardiac tamponade is a condition where the heart is compressed by fluids that are filled around the heart, and this can happen by blood or even effusion, and so because of the fluid in the pericardium, it will cause a compression to the heart,
and this leads to decrease in cardiac output, which happens due to the compression on the heart that it's not allowing the heart to pump out sufficient blood. What happens to diastolic pressure in all four chambers during a cardiac tamponade? There is an equalization of diastolic pressure in all four chambers in cardiac tamponade. What are some of the findings observed in cardiac tamponade? Some of the findings include hypotension, increase in the venous pressure that leads to jugular venous distension. There is also a distant heart sound that can be heard, increase in the heart rate, and pulsus paradoxus. What is pulsus paradoxus? Pulsus paradoxus is a decrease in the amplitude of systolic blood pressure by greater than or equal to 10 mmHg during inspiration. What are some of the conditions in which you would see pulsus paradoxus? Some of the conditions in which you would see pulsus paradoxus include severe cardiac tamponade, asthma, obstructive sleep apnea, pericarditis, and croup. Syphilitic heart disease. Describe syphilitic heart disease. Syphilitic heart disease is a condition that happens in tertiary syphilis that disrupts the vasa vasorum of the aorta, and this will lead to an atrophy of the vessel walls and therefore eventually will lead to a dilation of the aorta and the valve ring. What are some of the areas where calcification can happen in syphilitic heart disease? The calcification may happen in the aortic root and the ascending aorta arch. In syphilitic heart disease, what is a term that's given to describe the appearance of the aorta? In syphilitic heart disease, the term given to the aorta to describe its appearance is known as the tree bark appearance. What are some of the complications that can arise from syphilitic heart disease? Due to the effect it has on the aorta, it can lead to aneurysms of the ascending aorta or the aortic arch and can lead to aortic insufficiency. Cardiac tumors. What is the most common primary cardiac tumor in adult? The most common primary cardiac tumor in adult is myxomas. What is the primary location where myxomas appear? Myxomas 90% of the time occur in the atria, most commonly the left atrium. Describe the physical appearance of a myxoma. Myxoma are usually described as a ball valve obstruction in the left atrium. What is a consequence of a ball valve obstruction of the left atrium? Due to a myxoma, if you have a ball valve obstruction in a left atrium, the most likely consequence from that will lead to multiple syncopal episodes. What is the most frequent primary cardiac tumor in children? The most frequent primary cardiac tumor in children is rhabdomyomas. What disease is rhabdomyomas associated with? Rhabdomyomas are associated with tuberous sclerosis. In overall, what is the most common cause of heart tumor? The most common cause of heart tumor is generally due to metastasis, and this comes from melanoma or lymphomas. Kussmaul's sign. What is Kussmaul's sign? Kussmaul's sign is an increase in jugular venous pressure on inspiration instead of a normal decrease in jugular venous pressure. Describe what is happening during inspiration that would lead to the Kussmaul's sign. During inspiration, there would be a negative intrathoracic pressure that's not transmitted to the heart. This would lead to impaired filling of the right ventricles. Now, because of the impaired filling of the right ventricles, blood backs up into the vena cava. That means there would be a lot more blood in the vena cava, which would lead to that jugular venous distension. What are some of the conditions in which you would see the Kussmaul's sign? Some of the conditions in which you would see Kussmaul's sign is constrictive pericarditis, restrictive cardiomyopathies, right atrial or ventricular tumors, or also cardiac tamponade. Raynaud's phenomenon. What is Raynaud's phenomenon? Raynaud's phenomenon is a decrease in the blood flow to the skin due to arteriolar vasospasms in response to cold temperature or emotional stress. What are some of the areas affected by Raynaud's phenomenon? Raynaud's phenomenon most often occurs in the finger and toes. What is the difference between Raynaud's disease and Raynaud's syndrome? It's called Raynaud's disease when Raynaud's phenomenon is the only thing that's happening wrong in the body. So it's just happening in the body without there being any other underlying known diseases. And it's called Raynaud's syndrome when it happens secondary to a disease process such as mixed connective tissue disease, SLE, which is the systemic lupus erythematosus, or it can happen also in CREST syndrome, which is limited form of systemic sclerosis. Vasculitis affecting the large vessels. Name the two vasculitis that affect large vessels. The two vasculitis that affects large vessels includes temporal giant cell arteritis as well as Takayasu's arteritis. What group of patients are commonly affected with temporal giant cell arteritis?
The group of patients that are most commonly affected with temporal giant cell arteritis includes elderly female. What would be the primary complaint of a patient suffering from temporal giant cell arteritis? Primary complaint would be unilateral headache that would happen due to temporal artery involvement as well as jaw claudications. What is one major complication that can arise from patients suffering from temporal giant cell arteritis? A major complication that can arise is irreversible blindness due to ophthalmic artery occlusion. What is another disease that's associated with temporal giant cell arteritis? Another disease associated with temporal giant cell arteritis is polymyalgia rheumatica. What are some of the main arteries that are affected with temporal giant cell arteritis? The most common arteries that are involved here are branches of the carotid artery. What type of inflammation would be caused by temporal giant cell arteritis? There would be focal granulomatous inflammation. What would happen to the erythrocyte sedimentation rate in temporal giant cell arteritis? The erythrocyte sedimentation rate would increase. What is the treatment for temporal giant cell arteritis? The treatment for this is high-dose corticosteroids. What group of patients are primarily affected with Takayasu's arteritis? The group of patients that are affected with Takayasu's arteritis are Asian females under the age of 40 years old. What are some of the signs and symptoms of Takayasu's arteritis? Some of the signs and symptoms includes fever, night sweats, arthritis, myalgias, skin nodules, ocular disturbances, and there will also be weak upper extremity pulses, and that's why this disease is known as the pulseless disease. What are some of the pathological signs of Takayasu's arteritis? Some of the pathological signs includes granulomatous thickening of the aortic arch as well as the proximal great vessels. What would happen to the erythrocyte sedimentation rate in Takayasu's arteritis? The erythrocyte sedimentation rate increases in Takayasu's arteritis. What is a treatment for Takayasu's arteritis? The treatment for Takayasu's is to treat it with corticosteroids. Vasculitis of medium-sized vessels. Name the 3 vasculitis that affect medium-sized vessels. The 3 vasculitis includes polyarteritis nodosa, Kawasaki's disease, as well as Buerger's disease, also known as thromboangiitis obliterans. What group of patients are commonly affected with polyarteritis nodosa? The group of patients most commonly affected are young adults, as well as hepatitis B seropositivity happens to be in about 30% of the patients. What are some of the signs and symptoms of polyarteritis nodosa? Some of the signs and symptoms of this includes fever, weight loss, malaise, headache. In the GI, it would also give you abdominal pain and melena, as well as hypertension, neurological dysfunction, cutaneous eruptions, as well as renal damage. What is melena? Melena is a condition in which a patient has dark, sticky feces, and this is because the feces has partly digested blood. What group of vessels are most commonly involved in polyarteritis nodosa? Polyarteritis nodosa typically involves renal and visceral vessels, but it does not have an effect on the pulmonary arteries. Describe the pathology of polyarteritis nodosa. The pathology of this is that there would be transmural inflammation of the arterial wall with fibrinoid necrosis. The lesions are going to be of different ages. There are going to be many aneurysms as well as constrictions on the arteriogram. This condition is also immune complex mediated. What is some of the treatment for polyarteritis nodosa? Polyarteritis nodosa is treated with corticosteroids as well as cyclophosphamide. What group of patients are most commonly affected with Kawasaki's disease? Kawasaki's disease most commonly happens in Asian children under the age of 4. What are some of the signs and symptoms of Kawasaki disease? Some of the signs and symptoms of Kawasaki disease includes fever, cervical lymphadenitis, conjunctivitis, as well as changes in the lip and the oral mucosa, which would lead to a strawberry tongue. There would also be hand and foot erythema, as well as desquamating rash. What are some of the complications that can arise from Kawasaki disease? Some of the complications that may arise from Kawasaki disease includes coronary aneurysms that can lead to an MI or even aneurysm rupture. What is the treatment for Kawasaki disease? The treatment of Kawasaki disease is IV immunoglobulins and aspirin. What group of patients are most commonly affected with Buerger's disease, also known as thromboangiitis obliterans? The group of patients that are most commonly affected with this are heavy smokers and are usually males under the age of 40. Describe the presentation of a patient with Buerger's disease. The presentation of the patient would include intermittent claudication, may lead to gangrene, as well as autoamputation of digits, as well as superficial nodular phlebitis. Describe how intermittent claudication may lead to gangrene. The reason this is happening is because of the vasculitis, there's not enough blood supply going to your leg. For this reason, you would first of all have intermittent claudication. And because of the lack of blood supply, it will end up killing the tissue, therefore you would have gangrene. Define phlebitis. Phlebitis just simply means inflammation of the veins. One other thing to note about this disease is there would also be a Raynaud's phenomenon that would be present in this condition. What is the pathological characteristic of Buerger's disease? The pathological characteristic of this is that it's known as segmental thrombosing vasculitis. What is the treatment of Buerger's disease? The treatment for Buerger's disease is to stop smoking. Vasculitis affecting small vessels. Name the 4 small vessel vasculitis. The vasculitis includes microscopic polyangiitis, Wegener's granulomatosis, which is just granulomatosis with polyangiitis, along with Churg-Strauss syndrome, and Henoch Schonlein purpura. What is microscopic polyangiitis? Microscopic polyangiitis is a necrotizing vasculitis commonly involving the lung, kidney, and skin with pauci-immune glomerulonephritis and a palpable purpura. Is there granuloma formation in microscopic polyangiitis? There is no granulomas. Which autoantibody is microscopic polyangiitis positive for? Microscopic polyangiitis is positive for P-ANCA. What is the treatment for microscopic polyangiitis? The treatment for microscopic polyangiitis is cyclophosphamide as well as corticosteroids. Describe the areas Wegener's granulomatosis affects. Wegener's granulomatosis has an effect on the upper respiratory tract, lower respiratory tract, as well as the kidneys. What is the triad for Wegener's granulomatosis? The triad of Wegener's granulomatosis includes focal necrotizing vasculitis, necrotizing granulomas in the lung and the upper airway, as well as necrotizing glomerulonephritis. Describe the presentation of Wegener's granulomatosis due to its effect on the upper respiratory tract. Due to the involvement of the upper respiratory tract, there is going to be perforation of the nasal septum, chronic sinusitis, otitis media, as well as mastoiditis. Describe the presentation that Wegener's granulomatosis is going to have because of its involvement on the lower respiratory tract. Due to its involvement on the lower respiratory tract, there's going to be hemoptysis, cough, as well as dyspnea. Describe the presentation of Wegener's granulomatosis due to its effect on the kidneys. Due to its effect on the kidneys, it will have hematuria and red cell casts. Wegener's granulomatosis is positive for which autoantibody? Wegener's granulomatosis is positive for C-ANCA. Describe the appearance of a chest X-ray in Wegener's granulomatosis. On a chest X-ray, you would see large nodular densities. What is the treatment for Wegener's granulomatosis? Wegener's granulomatosis is treated with cyclophosphamide as well as corticosteroids. Describe the presentation of Churg-Strauss syndrome. Patients with Churg-Strauss syndrome will present with asthma, sinusitis, palpable purpura, and peripheral neuropathy, such as wrist or foot drop. Churg-Strauss syndrome can also have an impact on the heart, GI, as well as the kidney, and that would be the pauci-immune glomerulonephritis. Describe the pathology of Churg-Strauss syndrome. The pathology of this would include granuloma formation as well as necrotizing vasculitis with eosinophilia. What autoantibody is Churg-Strauss syndrome positive for? Churg-Strauss syndrome is positive for P-ANCA autoantibody. Levels of what immunoglobulin would be elevated in Churg-Strauss syndrome? In Churg-Strauss syndrome, there would be an elevated level of IgE. What is the most common childhood systemic vasculitis? The most common childhood systemic vasculitis is Henoch Schonlein purpura. And one thing to note about this is that it follows a upper respiratory tract infection. What is the classic triad for Henoch Schonlein purpura? The classic triad is that on the skin there would be a palpable purpura on the buttocks or the leg. There would also be arthralgia. In the GI, there would be abdominal pain, melena, and multiple lesions of the same age. Henoch Schonlein purpura is a vasculitis that happens secondary to what? It happens secondary to IgA complex deposition. What other condition is Henoch Schonlein purpura associated with? Henoch Schonlein purpura is associated with IgA nephropathy. Vascular tumors. Name all the vascular tumors. The vascular tumors include strawberry hemangioma, cherry hemangioma, pyogenic granuloma, cystic hygroma, glomus tumor, bacillary angiomatosis, angiosarcoma, lymphangiosarcoma, and Kaposi sarcoma. What is strawberry hemangioma? Strawberry hemangioma is a benign capillary hemangioma of infancy. It appears in the first few weeks of life in about 1 out of 200 births, grows rapidly, and regresses spontaneously at 5 to 8 years of age. What is cherry hemangioma? Cherry hemangioma is a benign capillary hemangioma of the elderly, does not regress, and the frequency of this increases with age. What is pyogenic granuloma? Pyogenic granuloma is a polypoid capillary hemangioma that can ulcerate and bleed. What is pyogenic granuloma associated with? Pyogenic granuloma is associated with trauma and pregnancy. What is cystic hygroma? Cystic hygroma is a cavernous lymphangioma of the neck. What is lymphangioma? Lymphangioma is a benign angioma consisting of a mass of lymphatic vessels. What condition is associated with cystic hygroma? Cystic hygroma is associated with Turner syndrome. What is glomus tumor? Glomus tumor is a benign, painful, red to blue tumor under the fingernails. What cells do glomus tumor arise from? Glomus tumor arises from the modified smooth muscle cells of the glomus body. What is bacillary angiomatosis? Bacillary angiomatosis is a benign capillary skin papule found in AIDS patients. What infection can cause bacillary angiomatosis? Bacillary angiomatosis is caused by Bartonella henselae infection. What disease is bacillary angiomatosis most frequently mistaken for? Bacillary angiomatosis is frequently mistaken for Kaposi's sarcoma. What is angiosarcoma? Angiosarcoma is a rare blood vessel malignancy typically occurring in the head, neck, or breast area. What are some of the conditions associated with angiosarcoma? Angiosarcoma is associated with patients receiving radiation therapy, especially for breast cancer or Hodgkin's lymphoma. One thing to note about angiosarcoma is that it's very aggressive and it's difficult to resect due to the delay in diagnosis of this. What is lymphangiosarcoma? Lymphangiosarcoma is a lymphatic malignancy associated with persistent lymphedema, which can happen post-radical mastectomy. What is mastectomy? Mastectomy is a surgical operation to remove the breast. What is Kaposi's sarcoma? Kaposi's sarcoma is an endothelial malignancy most commonly occurring in the skin, but can also occur at the mouth, GI tract, and respiratory tract. What other diseases is Kaposi's sarcoma associated with? Kaposi's sarcoma is associated with the human herpes virus 8 and HIV. What is Kaposi's sarcoma commonly mistaken for? Kaposi's sarcoma is frequently mistaken for bacillary angiomatosis. Sturge Weber disease. What is Sturge Weber disease? Sturge Weber disease is a congenital vascular disorder that affects capillary-sized blood vessels. Describe the manifestation of Sturge Weber disease. Sturge Weber disease manifests with port wine stain, which is the nevus phlegmius on the face. There is also ipsilateral leptomeningeal angiomatosis, which is a type of intracerebral arteriovenous malformation. These patients would also have seizures as well as early onset of glaucoma. One thing to note about Sturge Weber disease is that it affects small vessels. Anti-hypertensive therapy. What are some of the drugs used in the treatment of essential hypertension? The drugs used in the treatment of essential hypertension includes diuretics, ACE inhibitors, angiotensin II receptor blockers, also known as ARBs, and calcium channel blockers. What are the drugs used in the treatment of hypertension in patients that have congestive heart failure? The drugs used in the treatment for hypertension in patients that have congestive heart failure includes diuretic, ACE inhibitors, as well as ARBs, as well as beta blockers used in compensated congestive heart failure, and potassium-sparing diuretics. Describe how beta blockers should be used in antihypertensive therapy in patients with congestive heart failure. Beta blockers can be used freely in compensated congestive heart failure, but should be used with caution in decompensated congestive heart failure. One other thing to note about beta blockers are they are contraindicated in cardiogenic shock. Name some of the drugs used to treat hypertension in patients with diabetes mellitus. Some of the drugs used in this treatment is ACE inhibitors as well as ARBs, along with calcium channel blockers, diuretics, beta blockers, as well as alpha blockers.
Which group of drugs used in the treatment of hypertension in patients with diabetes mellitus is protective against diabetic nephropathy? The drugs that are protective against diabetic nephropathy are ACE inhibitors. Calcium channel blockers. Name some of the calcium channel blockers. Calcium channel blockers include nifedipine, verapamil, diltiazem, and amlodipine. Describe the mechanism of action of calcium channel blockers. The mechanism of action is to block voltage-dependent L-type calcium channels of cardiac and smooth muscle and thereby reducing muscular contractility. Name the calcium channel blockers in order for the most effective to least effective in vascular smooth muscle. In vascular smooth muscle, amlodipine has an equal effect as nifedipine, followed by diltiazem, followed by verapamil. Describe the order of calcium channel blockers from most effective to the least effective in the heart. The calcium channel blocker that is most effective on the heart is verapamil, followed by diltiazem, followed by amlodipine, just as equally as nifedipine. So basically the order is switched in the heart, then in the vascular smooth muscle. What is a short mnemonic to help you remember that verapamil has the greatest effect on the heart? A short mnemonic is to remember that verapamil has the letter V in it, and also ventricles have the letter V in it. So V for verapamil, V for the ventricles. What are all the clinical uses of calcium channel blocker? Calcium channel blockers are used in the treatment of hypertension, angina, arrhythmias, Prinzmental angina, along with Raynaud syndrome. Which calcium channel blocker is not used in arrhythmias? A calcium channel blocker that is not used in arrhythmias is nifedipine. And the primary reason for this is because nifedipine has a greater effect on vascular smooth muscle than it does on the heart. So because it's not that effective on the heart, you would generally not use it in the treatment of arrhythmias. What are some of the side effects and toxicities of calcium channel blocker? Some of the toxicities and side effects of calcium channel blocker includes cardiac depression, AV block, peripheral edema, flushing, dizziness, and constipation. Hydralazine. What is the mechanism of action of hydralazine? Mechanism of action of hydralazine is to increase the cGMP, and this will lead to smooth muscle relaxation. Hydralazine also reduces the afterload, and it generally has a greater effect to dilate the arterioles than it does the veins. What are all the clinical uses of hydralazine? Hydralazine can be used in severe hypertension as well as congestive heart failure. In what condition is hydralazine a first-line therapy drug? Hydralazine is a first-line therapy drug for hypertension in pregnancy with methyl dopa. What is the reason why hydralazine is frequently co-administered with beta blocker? The reason hydralazine is frequently co-administered with beta blocker is to prevent reflex tachycardia. What are some of the side effects and toxicities of hydralazine? Some of the side effects and toxicities of hydralazine includes compensatory tachycardia, and this is why they are contraindicated in angina and coronary artery disease. Hydralazine can also lead to fluid retention, nausea, headache, angina, and also lupus-like syndrome. Malignant hypertension. What are some of the drugs commonly used in the treatment of malignant hypertension? The drugs commonly used includes nitroprusside, nicardipine, clevidipine, labetalol, and phenldopam. What is the mechanism of action of nitroprusside? Mechanism of action of nitroprusside is to increase the cGMP via the direct release of nitric oxide, and it's a short-acting drug. What is a side effect or a toxicity that can happen with nitroprusside? A side effect or toxicity of nitroprusside usage is that it can cause cyanide toxicity because it has the ability to release cyanide. What is phenldopam? Phenldopam is a dopamine D1 receptor agonist. What is the use of phenldopam? Phenldopam is used for coronary, peripheral, renal, and splanchnic vasodilation. What does the word splanchnic mean? Splanchnic just means that it's referring to the organ, usually to describe visceral organs. What is the mechanism of action of phenldopam? Phenldopam's mechanism of action is to decrease the blood pressure and increase natriuresis. Nitroglycerin and isosorbide dinitrate. What is the mechanism of action of nitroglycerin and isosorbide dinitrate? The mechanism of action of this is to vasodilate by releasing nitric oxide in smooth muscle, and this causes an increase in the cGMP, and this leads to smooth muscle relaxation. Nitroglycerin and isosorbide dinitrate, they dilate the veins a lot more than they do the arteries, and therefore leads to decrease in the preload. So one thing you should note here is that Nitroglycerin is the opposite of hydralazine because in nitroglycerin you would have dilation of the veins a lot more than you would have arteries, and this leads to decrease in preload, whereas in hydralazine you have dilation of the arteries a lot more than you do the veins, and this leads to decrease in the afterload. What is the clinical use of nitroglycerin and isosorbide dinitrate? The clinical use is for angina as well as pulmonary edema. What are some of the side effects and toxicities of nitroglycerin and isosorbide dinitrate? Some of the toxicities and side effects include reflex tachycardia, hypotension, flushing, headache, and Monday disease. What is Monday disease? Monday disease is something that happens to people that are exposed to nitroglycerin all the time at work. And because of this reason, they develop a tolerance for vasodilation action during the work week and lose the tolerance over the weekend, results in tachycardia, dizziness, and headache upon re-exposure on the Monday when they come back to work. Anti-anginal therapy. What is the goal when you're trying to treat angina? The goal in the treatment of angina is to reduce the myocardial oxygen consumption by decreasing one or more of the determinant of the myocardial oxygen consumption, which is the MVO2. Therefore, if you decrease the end diastolic volume, this would mean the heart has to do less work to squeeze all that blood out of the chambers. Also, if you decrease the blood pressure, it also helps the heart not have to use so much oxygen in order to get all that blood out. Also, if you decrease the heart rate, it makes sense that the heart now will be doing less work, so the oxygen demand would be decreased. Also, contractility is another factor because then the heart doesn't have to contract so hard, and if it's contracting so hard, it needs more oxygen. So if you decrease contractility, it would also decrease the MVO2. And ejection time is the last thing. If you decrease the ejection time, it's taking less time for the heart to get rid of all that blood. So if you do that, this again will also require lesser oxygen by the heart. Does nitrate affect the preload or does it affect the afterload? Nitrates affect the preload. Do beta blockers affect preload or afterload? Beta blockers affects afterload. Describe how nitrates are used in the treatment of angina by reducing the myocardial oxygen consumption. The way nitrates are used in angina therapy is because they decrease the end diastolic volume, they also decrease the blood pressure, they have a reflex response in contractility, which will increase contractility, so it does not help out there. It also increases the heart rate, and this is also a type of reflex response, so it does not help out there. It decreases the ejection time, and in overall there would be a decrease in the myocardial oxygen consumption, so it is a drug that can be used in the treatment of angina. Describe how beta blockers are useful in the treatment of angina to decrease the myocardial oxygen consumption. The effect beta blocker has is, first of all, it does increase the end diastolic volume. Now the reason for this is because beta blocker generally has an effect on the afterload, not really an effect on the preload. Therefore, it is increasing that end diastolic volume, so it's not really beneficial here. But moving forward, it does decrease the blood pressure, so this is a good thing. It also decreases contractility and heart rate, so these are both good things. But it also has that increasing effect on the ejection time, again for that same reason, because beta blockers have an effect on afterload, not really preload. Therefore, it does increase that ejection time, but in overall, it does decrease the myocardial oxygen consumption. So overall, it is a drug used in the treatment of angina. Describe the effect that nitrates plus beta blocker therapy has on the treatment of angina. When nitrates and beta blockers are used together in the treatment of angina, it does overall have the greatest effect. Now, the reason for this is because the nitrate effect counteracts the beta blocker effect on the end diastolic volume, so therefore the net effect would be no change in the end diastolic volume, or there could be a decrease in end diastolic volume, so this is a good thing. Second thing would be to decrease the blood pressure, so both of these effects have that, so it does decrease the blood pressure. There would be little to no change in the contractility. The reason for this is because beta blocker decreases contractility, but the reflex response would increase the contractility of nitrate. Therefore, there would be little or no effect on the contractility. There would be a decrease in the heart rate because beta blocker does have a great effect on the heart rate. So therefore, with the use of beta blocker and nitrate together, there would still be a decrease in the heart rate. There would be little or no change in the ejection time because there is two opposite things that are happening. Nitrates decrease ejection time, whereas beta blockers increase it. So there would be little to no change on the ejection time. But overall, when both of these drugs are given together, it does have the greatest effect on reducing the myocardial oxygen consumption. So both of these drugs together is probably the primary therapy in the treatment of angina. Which calcium channel blocker has a similar effect to nitrates? The calcium channel blocker that has similar effect to nitrates is nifedipine. To remember this easily, just remember that nitrate starts with an N, and as well as nifedipine also starts with an N. Which calcium channel blocker has an effect similar to beta blockers? The calcium channel blocker that has an effect similar to beta blockers is verapamil. Why is pindolol as well as acebutolol, even though they are beta blockers, why are they contraindicated in angina? The reason pindolol and acebutolol, even though they are beta blockers, they are contraindicated, is because they are also partial beta agonists. So as well as antagonists, they're also agonists, so it's contraindicated in angina. Lipid-lowering agents. Name some of the HMG-CoA reductase inhibitors. The HMG-CoA reductase inhibitors include lovastatin, pravastatin, simvastatin, atorvastatin, and rosuvastatin. So these are all the drugs that have the statin ending, and they are the HMG-CoA reductase inhibitors. Which cholesterol is referred to as the bad cholesterol? The bad cholesterol is the LDL, or the low-density lipoprotein. Which cholesterol is referred to as the good cholesterol? The good cholesterol is the HDL, or the high-density lipoprotein. What is an effect that HMG-CoA reductase inhibitors have on the LDL, the HDL, and the triglycerides? HMG-CoA reductase inhibitors, such as all the statin drugs, has a great effect on decreasing the bad cholesterol, the LDL. So this is the major effect of these drugs, to decrease the LDL. Some of the minor effect includes increasing the HDL as well as decreasing the triglycerides. What is the mechanism of action of the HMG-CoA reductase inhibitors? The mechanism of action of this is to inhibit the conversion of HMG-CoA to mevalonate, which is the cholesterol precursor. What are some of the side effects or problems that can happen in a patient that is using HMG-CoA reductase inhibitors? Side effects of these drugs include hepatotoxicity and rhabdomyolysis. What is rhabdomyolysis? Rhabdomyo means the skeletal muscle, and lysis means the breakdown. So basically, rhabdomyolysis just means there is a rapid breakdown of the skeletal muscles. What is another name for vitamin B3 that can be used as a lipid-lowering agent? Another name for vitamin B3 is niacin. What are some of the effects that niacin has on the LDL, the HDL, and the triglycerides? Niacin has an effect on decreasing the LDL, which is the bad cholesterol, and it will also help increase the HDL, which is the good cholesterol. It will do both of these things equally. It also has an effect on decreasing the triglycerides. What is the mechanism of action of niacin? The mechanism of action of niacin is to inhibit lipolysis in the adipose tissue. It also reduces the hepatic VLDL secretion into the circulation. And the reason this is important is in the blood, the VLDL can eventually become LDL. What are some of the side effects or problems that can happen with niacin use? Niacin can lead to red flushed face, and this is reduced with the use of aspirin, or if you take niacin for a long time, this effect generally is decreased. It also leads to hyperglycemia, and this leads to acanthosis nigricans. And acanthosis nigricans is just a condition, it's a skin disorder in which the skin becomes darker, it becomes thick and velvety in the areas where the skin folds, and the body folds, or the creases. And the use of niacin can also lead to hyperuricemia. So if you have gout and you use niacin, it would exacerbate gout. Lipid-lowering agents. Name some of the bile acid resins. Bile acid resins include cholestyramine, cholestyramine, and cholesevelam. Describe the effects that bile acid resins has on the LDL, the HDL, and on the triglycerides. The bile acid resins has an effect on decreasing the bad cholesterol, which is the LDL. It will slightly increase the HDL, which is the good cholesterol, and it will slightly also increase the triglycerides. So this is the one negative effect that bile acid resins has. Other than that, it is a very good lipid-lowering agent. What is the mechanism of action of bile acid resins? Bile acid resins prevents the intestinal reabsorption of the bile acid. So the bile acid that had gone into the gut from the liver will not get reabsorbed, and now so therefore the hepatocytes will have a decreased amount of bile acid. What it needs to do now is to pull more cholesterol from the blood in order to make more bile acids. So in this process, the liver ends up taking more bad cholesterol out of the blood in order to make more bile acids, therefore decreasing the bad cholesterol. What are some of the side effects or problems that happens with bile acid resins? Some of the problems or side effects of this include that patient actually hates the drug. It tastes bad and causes GI discomfort. These group of drugs also decrease the absorption of fat-soluble vitamin and can also lead to formation of cholesterol gallstones. Name a cholesterol absorption blocker. A cholesterol absorption blocker is ezetimibe. What are some of the effects of ezetimibe on LDL, the bad cholesterol, HDL, and the triglycerides? Ezetimibe decreases the bad LDL cholesterol. It doesn't have any effect on the HDL, and it does not have any effect on the triglycerides. What is the mechanism of action of ezetimibe? The mechanism of action is to prevent cholesterol reabsorption at the small intestine brush border. What are some of the side effects or problems that can happen with the use of ezetimibe? Some of the side effects or problems that can happen is in rare cases there would be an increase in the liver function test and diarrhea can also happen. Name some of the drugs that are in the fibrates group of lipid-lowering agent. Some of the fibrates includes gemfibrozil, clofibrate, bezafibrate, and fenofibrate. What are the effects that fibrates have on the LDL, the HDL, and the triglycerides? Fibrates help to decrease the LDL, which is the bad cholesterol. It also helps to increase the good cholesterol, which is the HDL, but its major effect is on the triglycerides to decrease the level of triglycerides the most. What is the mechanism of action of the fibrates? The mechanism of action of fibrates is to upregulate the lipoprotein lipase, and in this way it increases the triglyceride clearance. What are some of the problems or side effects that can happen with the use of fibrates? Some of the problems and side effects that can happen with the use of fibrates is myositis, hepatotoxicity, and this is because there would be an increase in the liver function test. These group of drugs can also lead to cholesterol gallstone formation. What is myositis? Myositis is an inflammation and degeneration of the muscle tissue. Lipid-lowering agent. Describe the picture on page 281. First of all, let's get oriented with the picture. Starting from left to right, we're looking at the gut, the hepatocyte, the blood, and the endothelial cell. So from here, we're going to talk. You see where it shows ezetimibe. Now, ezetimibe's main function is to prevent the cholesterol reabsorption at the small intestine brush border. So that's what it's doing here. It's not letting the cholesterol go into the hepatocyte, and so that is how cholesterol ends up getting excreted by the body and does not get reabsorbed. So that is the action of ezetimibe, and that is a cholesterol absorption blocker. Now if you look at the hepatocyte, we're looking at how the cholesterol and the bile acids are made. Now looking at this picture, we see how acetyl-CoA eventually becomes HMG-CoA, HMG-CoA eventually becomes cholesterol, and cholesterol eventually becomes bile acid. There's multiple steps in the middle, but we're not going to talk about those. The important steps are what it's showing here. Now HMG-CoA becomes cholesterol, and the enzyme that it uses here is HMG-CoA reductase. Now if you use the drugs HMG-CoA reductase inhibitors, these drugs will prevent that conversion from happening, and therefore eventual formation of cholesterol would be blocked. So this is how cholesterol is decreased in the body. And now moving forward, we're going to talk about how bile acid resins come into play. Now as you can see in the picture here, eventually after cholesterol is made, then the bile acid gets made. What happens to the bile acid is it goes out into the gut, but then it has to get reabsorbed back, so the liver doesn't have to make more bile acid. So what bile acid resins do is it prevents that step from happening. It prevents that reabsorption. So it prevents the intestinal reabsorption of bile acid. Therefore, the liver must now go and get more cholesterol from the blood, and in this way make the bile acid. So it indirectly requires the liver to pull out more cholesterol from the blood, and in this way decreases the levels of cholesterol in the body. Now the next thing we're going to talk about is niacin. Now the effect of niacin doesn't let the VLDL get into the circulation. If VLDL doesn't get into the circulation, lipolysis doesn't happen. If lipolysis doesn't happen, there's not an increased level of cholesterol in the body. So this is the effect of niacin on decreasing the levels of cholesterol in the body. Now the last thing we're going to talk about is the fibrates. If you look at gemfibrozil in the picture here, it shows that it's upregulating the lipoprotein lipase, and then this will cause an increase in the clearance of the triglycerides out of the body. Cardiac glycoside. Name a cardiac glycoside. Cardiac glycoside is digoxin. What is the pharmacokinetics and the pharmacodynamics of digoxin? The pharmacokinetics and the dynamics of digoxin is 75% is bioavailable, 20 to 40% is protein bound, the half-life of digoxin is 40 hours, and it's urinarily excreted. The mechanism of action of digoxin is to directly inhibit the sodium-potassium ATPase, which leads to an indirect inhibition of the sodium-calcium exchanger or antiport. It will also lead to an increase in the levels of intracellular calcium, and this leads to positive ionotropy. It also stimulates the vagus nerve, and this decreases the heart rate. What are some of the clinical uses of digoxin? Some of the clinical uses of the cardiac glycoside digoxin is for congestive heart failure, and in this it would increase contractility. It's also used in the treatment of atrial fibrillation to decrease the conduction of the AV node and to cause a depression of the SA node. What are some of the cholinergic side effects or toxicities that can happen with digoxin use? Some of the cholinergic effects that digoxin has are nausea, vomiting, diarrhea, and blurry yellow vision. To help you remember blurry yellow vision, just think of Van Gogh's famous painting, in which the painting does look a little blurry and it does have yellow coloring. What are some of the ECG changes that you can see in digoxin toxicity? Some of the ECG changes in digoxin toxicity includes an increase in the PR, decrease in the QT, and ST scooping. There would also be a T-wave inversion, arrhythmia, and AV block. One other thing to note here is that digoxin toxicity can also lead to hyperkalemia, which is a poor prognostic indicator. What are some of the factors that can predispose you to digoxin toxicity? Some of the factors include renal failure. In renal failure, there will be decrease in excretion of digoxin, therefore the likeliness of toxicity is increased. Also, hypokalemia can lead to digoxin toxicity. The reason for this is in hypokalemia, it gives digoxin the permission to bind at the potassium binding site on the sodium-potassium ATPase. And lastly, if you're using a drug like quinidine, it will also increase the chance of getting digoxin toxicity. The reason for this is quinidine decreases digoxin clearance. It also displaces digoxin from the tissue binding site, therefore it will cause an increase in toxicity levels of digoxin in the body. What is an antidote to reverse digoxin toxicity? An antidote to reverse digoxin toxicity is to slowly normalize the potassium. You could also give lidocaine, cardiac pacemakers, anti-digoxin fab fragments, and magnesium. Anti-arrhythmics. What are the class 1 anti-arrhythmics? The class 1 anti-arrhythmics are the sodium channel blockers. What is the mechanism of action of the class 1 anti-arrhythmics? To answer this question and to help understand this, please also look at the picture on page 283. Class 1 anti-arrhythmics slow or block the conduction, especially in the depolarized cells. They decrease the slope of phase 0 depolarization and increase the threshold for firing in abnormal pacemaker cells. The sodium channel blockers are state dependent and they selectively depresses the tissue that is frequently depolarized. This is why they're good in tachycardias. What condition can cause an increase in toxicity of all the class 1 drugs? Hyperkalemia causes an increase in toxicity for all class 1 drugs. What are the three subclasses of the class 1 antiarrhythmics? The three classes include class 1A, class 1B, and class 1C. Name some of the drugs in class 1A antiarrhythmics. Some of the class 1A sodium channel blockers antiarrhythmics includes quinidine, procainamide, and disopyramide. What is the mnemonics to help you remember the class 1A sodium channel blockers antiarrhythmics? The mnemonics to help you remember this is just remember the quote, "The queen proclaims Disso's pyramid," where queen stands for quinidine, proclaims is the procainamide, and Disso's pyramid is disopyramide. What is the mechanism of action of class 1A antiarrhythmics? To answer this question, it's also helpful to look at the picture on page 283. The mechanism of action of class 1A antiarrhythmics is to increase the action potential duration. It increases the effective refractory period, the EPR, and it also increases the QT interval. What are some of the types of arrhythmias in which you would use class 1A antiarrhythmics? Class 1A antiarrhythmics are used in both atrial and ventricular arrhythmias. especially reentrant and ectopic supraventricular and ventricular tachycardia. What are some of the toxicities or side effects of using quinidine? The side effect and toxicity of using quinidine is synchronism, in which you would have headache and tinnitus. What is tinnitus? Tinnitus is the ringing of the ears. What is the side effect or toxicity of using procainamide? Side effect or toxicity of using procainamide is you would have reversible lupus-like syndrome. What is the side effect or toxicity that can happen with the use of disopyramide? The side effect or toxicity that can happen with the use of disopyramide is heart failure. What are some of the other side effects or toxicities that can happen with use of any of the class 1 antiarrhythmics? Some of the other toxicities include thrombocytopenia and torsades de pointe. The reason torsades de pointe can happen is because anything that increases the QT interval can lead to torsades de pointe. Define thrombocytopenia. Thrombocytopenia is when there is a deficiency of platelets in the blood. Anti-arrhythmics, sodium channel blockers, class 1B. What are some of the class 1B sodium channel blockers antiarrhythmics? Some of the class 1B drugs include lidocaine, mexiletine, and tokenide. What is the mnemonics to help you remember the drugs that are in the class 1B group of antiarrhythmics, the sodium channel blockers? The class 1B mnemonics to help you remember this is just remember the quote, "I would buy Liddy's Mexican tacos." The I'd buy part stands for the class 1B, Liddy's is for lidocaine, Mexican is for mexiletine, and tacos is for tokenide. What is the mechanism of action of the class 1B sodium channel blockers antiarrhythmics? The mechanism of action is to decrease the action potential, and it preferentially affects the ischemic or the depolarized Purkinje and the ventricular tissues. In what situation are the class 1B sodium channel blockers antiarrhythmics useful? The class 1B sodium channel blockers are useful in acute ventricular arrhythmias, especially post-MI and in digitalis-induced arrhythmias. What are some of the toxicities and side effects of using class 1B sodium channel blockers antiarrhythmics? Some of the toxicities include CNS stimulation or depression, and they can also lead to cardiovascular depression. One other thing to note about them is some of the drugs in this group are also used as local anesthetics. One other thing to also note is to remember that the class 1B sodium channel blockers antiarrhythmics are best post-MI. What is another name of a drug that we have not talked about that also falls under the class 1B category of sodium channel blocker antiarrhythmics? The name of that drug is phenytoin. Name some of the drugs that fall under the class 1C sodium channel blockers antiarrhythmics. Some of the drugs in the class 1C category include flecainide and propafenone. Describe the effect that class 1C sodium channel blockers antiarrhythmics have on the action potential. Class 1C sodium channel blocker antiarrhythmics does not have an effect on the action potential. In what situation are the class 1C sodium channel blockers antiarrhythmics useful in? Class 1C antiarrhythmics are useful in ventricular tachycardias that progress to ventricular fibrillation and in intractable supraventricular tachycardia. They are usually only used as a last resort in refractory tachyarrhythmias for patients without structural abnormalities. What is the difference between class 1B and class 1C antiarrhythmics in terms of their usefulness in arrhythmias? Class 1B antiarrhythmics is best post-MI, whereas class 1C is contraindicated post-MI, and it's also contraindicated in patients that have structural heart disease. What are some of the toxicities or side effects that can arise from class 1C antiarrhythmics? Some of the toxicities and side effects of class 1C antiarrhythmics is they can also be proarrhythmic, especially post-MI, so therefore they are contraindicated post-MI and should not be given. These group of drugs can also significantly prolong the refractory period of the AV node. Class 2 antiarrhythmics. What are the class 2 antiarrhythmics? The class 2 antiarrhythmics are beta blockers. Name some of the beta blockers that are used as class 2 antiarrhythmics. Some of the beta blockers that are used as class 2 antiarrhythmics include metoprolol, propranolol, esmolol, atenolol, and timolol. So these are the drugs that have the lol ending. What is the mechanism of action of the class 2 antiarrhythmics, the beta blockers? The mechanism of action is to decrease the SA and the AV nodal activity by decreasing the CAMP and decrease the calcium currents. They also work to suppress abnormal pacemakers by decreasing the slope of phase 4. AV node is particularly sensitive to the beta blockers, and this can cause an increase in the PR interval. Name a very short-acting beta blocker. Esmolol is a very short-acting beta blocker. What are some of the clinical uses of the class 2 antiarrhythmics, the beta blockers? The clinical uses of this are in ventricular tachycardia, supraventricular tachycardia, and it's also useful in slowing the ventricular rate during atrial fibrillation and in atrial flutter. What are some of the toxicities or side effects that can happen with class 2 antiarrhythmics, the beta blockers? Some of the side effects and toxicities that could happen includes impotence, exacerbation of asthma, cardiovascular effects such as bradycardia, AV block, and congestive heart failure. There's also CNS effects such as sedation, sleep alteration, and these group of drugs may also mask the sign of hypoglycemia, therefore should be used with caution in diabetic patients. What is the name of the beta blocker that can also cause dyslipidemia? The beta blocker that can cause dyslipidemia is metoprolol. What drug can be used as an antidote to counter the effect of beta blockers? Beta blocker overdose is treated with glucagon. What drug can exacerbate vasospasm in Prinzmental's angina? The drug that can do this is propranolol. Class 3 antiarrhythmics. What are the class 3 antiarrhythmics? The class 3 antiarrhythmics are the potassium channel blockers. Name some of the potassium channel blockers. Some of the potassium channel blockers includes amiodarone, ibutylide, dofetilide, and sotalol. What is the mnemonics to help you remember some of the class 3 antiarrhythmics? The mnemonics to help you remember this is AIDS, which stands for amiodarone, I is for ibutylide, D is for dofetilide, and S is for sotalol. What is the mechanism of action of the class 3 antiarrhythmics, the potassium channel blockers? The mechanism of action is to increase the action potential duration, as you can see here in the picture, as well as increase the effective refractory period. These group of drugs are used when all other antiarrhythmics fail. These drugs can also increase the QT interval, which means the chances of getting Torsades de Pointes also increases. What are some of the side effects and toxicities that can happen when using the drug sotalol? Some of the side effects and toxicities that can happen when using the drug sotalol is Torsades de Pointes, and it can also cause excessive beta blockage because sotalol is also a beta blocker. What is a side effect and toxicity that can happen when using the drug ibutylide? Ibutylide usage can also lead to Torsades de Pointes, and this is again because of the same reason, because this drug causes an increase in the QT interval. What are some of the side effects and toxicities that can happen when using the drug amiodarone? Some of the side effects and toxicities that can happen with amiodarone includes pulmonary fibrosis, hepatotoxicity, hypothyroidism or hyperthyroidism, and the reason for this is amiodarone is 40% iodine by weight. It can also lead to corneal deposits, skin deposits, which can have blue or gray coloring. It can also result in photodermatitis, neurological effects, constipation, cardiovascular effects such as bradycardia, heart block, or even congestive heart failure. Why does amiodarone have class 1, 2, 3, and 4 antiarrhythmic effects? The reason for this is that amiodarone can alter the lipid membrane. What are all the lab values that needs to be followed when using amiodarone? When using amiodarone, you have to remember to check the pulmonary function test, liver function test, and the thyroid function test. Class 4 antiarrhythmics. What are the class 4 antiarrhythmics? The class 4 antiarrhythmics are the calcium channel blockers. Name some of the calcium channel blockers that can be used as antiarrhythmics. The calcium channel blockers that can be used as antiarrhythmics are verapamil and diltiazem. What is the mechanism of action of the class 4 antiarrhythmics, the calcium channel blocker? The mechanism of class 4 antiarrhythmics is to decrease the conduction velocity, increase the effective refractory period, and also increases the PR interval. What is the clinical use of the class 4 antiarrhythmics, the calcium channel blocker? The clinical use is to prevent nodal arrhythmias such as supraventricular tachycardias. What are some of the side effects and toxicities of using class 4 antiarrhythmics, the calcium channel blockers? The toxicities of this includes constipation, flushing, edema, cardiovascular effects such as congestive heart failure, AV block, and sinus node depression. Other antiarrhythmics. Name some of the drugs that we have not talked about that can be used as antiarrhythmics. Some of the drugs that we have not talked about that are also used as antiarrhythmics include adenosine and magnesium. What is the mechanism of action of adenosine? The mechanism of action of adenosine is to increase the potassium out of the cell. Whenever potassium goes out of the cell, it leads to hyperpolarization of the cell, and it also leads to a decrease in the influx of calcium. What is the clinical use of adenosine? Adenosine is the drug of choice in diagnosing or abolishing supraventricular tachycardia. And the reason it's used for this is because it's very short acting. It only lasts about 15 seconds. What are some of the side effects and toxicities that can happen with the use of adenosine? Toxicities include flushing, hypotension, and chest pain. What are some of the things that can reverse the effect of adenosine? The effects of adenosine are blocked by theophylline or caffeine. What is the clinical use of magnesium in arrhythmias? Magnesium is effective in torsades de pointes as well as digoxin toxicity.